Committee will come to order, and I want to welcome everyone. I think we've got a great turnout, some excellent witnesses this afternoon, and exploring an important subject. While many of us in Washington are here in Washington today for transactions, many of our colleagues are scattered across the country for this virtual hearing, and even those of us here in Washington are not gathered in the committee room. So in compliance with the regulations for remote committee proceedings pursuant to House Resolution 8, we will follow those, and the authority has allowed us to continue to do this work while we are spread across the country. Before we turn to today's important topic, just a few ground rules as we navigate the hearing. First, consistent with H.R. 8, the committee will keep microphones muted to limit background noise. Members are responsible for unmuting when they seek recognition or being recognized for their questioning. Second, members and witnesses must have their cameras on while present in the hearing. If you need to step away, please turn off your camera and audio and then log out. Finally, I believe that we are in good shape as far as the voting schedule this afternoon. We should be able to complete our work before votes reoccur. It's my intention to continue proceedings throughout this period. If I have any technical difficulties, as I did for a moment signing in this afternoon, I'll ask Mr. Thompson from California to act as chair while I get rejoined. I thank all of you for your patience as we navigate this technology and continue serving our country. I will now proceed to an opening statement and then call on Mr. Nunes for his opening statement. Though we have great scientific achievements that we're all very happy about, this week we have mourned the tragic toll of 500,000 Americans lost to COVID-19. And the numbers don't tell it all because it's a friend, a neighbor, a family member that has been lost. And we know that more deaths and infections are on the way until we get most Americans immunized and until we're assured that we have protection from the various variants that are cropping up now. Turning vaccines into vaccinations has been incredibly chaotic. So much of the spread of infection and rising death toll could have been prevented by effective federal leadership relying on good science. It's truly incredible to me that our country, advanced as it is, could have the highest percentage of deaths of any place in the entire world. After extraordinary overpromising and under-delivering last year, President Trump, you'll remember, promised 100 million doses would be out before New Year's Eve, then lowered it to 20 million, and still was not by New Year's Eve to even forward that many doses out, much less get them into people's arms. To date, our healthcare workers and long-term care residents who are in Group 1A have not all been vaccinated, and those who await in 1B face great uncertainty. President Biden was left without an immunization plan, sufficient vaccine, and with what can only be described, I think, as a colossal mess. Today's hearing is focused on the path forward as we have safe and effective vaccines and a humane administration that wants to offer leadership and partnership. In a little more than a month, President Biden has begun stabilizing vaccine production and distribution, increasing supply. We have these new federal initiatives, including the FEMA mass vaccination hubs across the country, a direct-to-pharmacy dose, direct partnership with community health centers, and yet we do still face a number of problems. For each of us as members of this committee, regardless of party, I think our concern about vaccine access begins at our home area. In my part of Texas, we're still not where we need to be. Too many vaccine providers remain unsure when and how many doses they'll receive. The state may be getting notice from the Biden administration of 3 weeks or now months, but that notice is not getting on to the actual healthcare providers. Seniors wait anxiously, calling, unable to get into one central registry in most places, often trying to get on the list of every provider anywhere in the area, and then finding themselves at these mass vaccination sites in long lines. For many, appointments are only available online. If they lack the skills to use broadband or they don't have broadband, they don't get considered. Vaccination sites also remain concentrated in wealthier white areas, making it difficult for those who borne the greatest infection burden to access shots. In some areas, the state has been a problem. That's been true of an important site at the Alamo Dome in San Antonio, where we have been unable to get from the governor a certainty of the supply that will be available. As President Biden recognized in his COVID-19 Health Equity Task Force, the burden, of course, has not been shared equally. Nationally, Latinos are more than 3 times more likely to be hospitalized and 2.3 times more likely to die from the virus as compared to Anglos. African Americans, Asian Americans have also suffered. Yet nationally, only 3% of Latinos have been vaccinated, and that's true in my home state also. While wonderful to have these safe and effective vaccines as a strong defense against the virus, taxpayers have an interest in knowing the terms of the agreements made to obtain defense and what we paid for them and what it will cost in the future. The Trump administration hid all that it could about these secret agreements with vaccine makers. And what we do know is that this Congress has appropriated billions and billions for vaccines with essentially no limitations on how the money is expended. Today, in response to that, in a bipartisan, bicameral initiative, I filed the TRACK Act, that's Taxpayer Research and Coronavirus Knowledge Act, to secure that information. We will explore accountability, how we get reasonable pricing and sufficient expedient supply of vaccines, which rightfully the taxpayers have funded largely as angel investors in this enterprise. That becomes particularly important as we recognize that we may well need these vaccines, much like a flu shot with boosters in the future, long after an emergency has been ended. While too many still wait for the vaccine, there are other people who wait in fear, who are hesitant to be vaccinated. Some worry because of problems in the past with medical racism in our country, but for many that hesitancy is tied directly to the false notion and conspiracy theories of anti-vaxxers. Failure to seek immunization, just like failure to wear a mask or social distance, will result in even more infection and death. I think we have to directly rebut the anti-vaxxer, anti-science message. At the same time, there are some people who are vaccinated, a very, very small portion, perhaps about 1 out of a million, that actually do suffer some injury. Most of these are not related to the vaccine, but the way the vaccine is administered. There is a longstanding vaccine injury compensation program, but it has not been updated for many years. And I think it will be important to do that as I propose in new legislation, a Vaccine Compensation Modernization Act. There are many other challenges that we explore today. After watching the production of Hamilton, I think the American Medical Association leadership chose as their campaign slogan, "This is our shot." Well, our goal today is to ensure that we make the most of our shot for our country to defeat this virus. I want to thank our panel for joining us, our colleagues for being here for such a good turnout, because it reflects, while we may have differing insights, it reflects a common concern and desire to address this challenging problem. And with that, I would call on my colleague and our ranking member, Mr. Nunes, for his opening comments.
Well, thank you very much, Chairman Doggett, for calling this hearing, and I want to thank all 6 of our witnesses for being here today. We are happy to have your expertise. Before we start, point of process. As Chairman, over the past 2 subcommittee hearings you've presided over, you've invited 11 witnesses to our 2, especially on bipartisan issues like this one. I would hope that going forward, you would allow more proportional ratio of witnesses and witness invitations for the minority. It is truly remarkable that less than a year after President Trump declared a national emergency over COVID-19 outbreak, we are here to discuss COVID-19 vaccines that are already being distributed and administered to the American public. We would not be in this position without the incredible efforts of Operation Warp Speed, a Trump administration-led initiative to accelerate and facilitate the aggressive development and manufacturing of COVID-19 vaccines. Due to the program's tremendous work, the FDA has approved 2 double-dose vaccines from Pfizer and Moderna. Additionally, a single-dose vaccine from Johnson & Johnson could be issued an emergency use authorization as soon as today. I believe it did receive that, if the news reports are correct. Vaccines from other companies such as AstraZeneca and Novavax are in late phase clinical trials. It is plausible that we could achieve herd immunity by the end of this summer and achieve our goal of crushing the COVID-19 virus and getting American lives back to pre-pandemic normalcy. To reach the finish line, Congress should focus on 4 key priorities. First, we must take the lessons learned from states whose vaccination campaigns have been the most successful and apply them to other states and localities to get as many Americans vaccinated as fast as possible. In my home state of California, vaccine distribution has been slow, confusing, and a frustrating process. Governor Newsom's vaccine rollout has been plagued by technical glitches and distribution problems, and California continues to lag behind many other states in overall vaccinations. Overburdened areas, like the area I come from, the Central Valley, as well as Los Angeles, are dealing with dwindling supplies and have struggled to meet overwhelming demand for the vaccine. By contrast, states like West Virginia are successfully vaccinating their elderly and high-risk populations. Today, we will hear testimony from Dr. Clay Marsh, West Virginia's coronavirus czar, on the techniques they use to achieve this success, such as using COVID-19 vaccine hotline, implementing a decentralized hub and spoke model for local pharmacies to participate in vaccinations, and crafting clear priority schemes to guide who gets vaccinated and when. While each state must tailor its vaccine distribution process to meet the needs of its unique population, our governors and local health officials should take note of what practices work best so we can vaccinate Americans as quickly as possible. Second issue, given the threat of COVID-19 virus mutations, we must improve domestic manufacturing and enhance supply chain logistics. While our current available vaccines show effectiveness against strains, manufacturers are gathering more data and preparing more booster shots to bolster vaccine effectiveness. Last October, Ways and Means Republicans introduced the Commitment to American Growth Act to incentivize American medical independence and boost our business investments in manufacturing innovation. With these measures, we can reduce our dependence on China and other countries, encourage small biotech companies to boost American manufacturing, and ultimately improve public health. Third issue, as we ramp up our vaccine production and inoculate more Americans with COVID-19 vaccines, President Biden needs to start following the recommendations of CDC and begin supporting the safe reopening of in-person schooling. In a February White House press briefing, CDC Director Walensky noted there is increasing data to suggest schools can safely reopen, regardless of whether teachers are vaccinated. Additional data has shown that at least 75% of communities in the U.S. can reopen schools without generating new COVID-19 outbreaks. By adhering to CDC protocols of mask wearing, social distancing, and improved ventilation, we can combine these efforts with wide-scale vaccinations to create a safe environment for teachers and students to swiftly return to the classroom. And finally, we must address concerns over the vaccine and emphasize that receiving the COVID-19 vaccine is safe, effective, and will bring us closer to our goal of herd immunity and a return to normal. Data shows that as of January 21st, 31% of Americans still want to wait to see how the vaccine is working before taking it, while 13% of Americans say they definitely do not want to take the vaccine. In light of concerns over the novelty of the vaccine, potential side effects, and the government approval process, leaders need to amplify the science that demonstrates that receiving COVID-19 vaccine is not only safe and effective, but will reduce the threat of serious complications and illness from COVID-19 and improve our overall health. I want to thank you, Mr. Chairman, and yield back and look forward to listening to our witnesses.
Thank you very much, Mr. Nunes. And without objection, all members have an opportunity to submit an opening statement for inclusion in our record. I will now welcome our panel of distinguished witnesses, and we are fortunate to have such a strong panel today. First, Dr. Ashish Jha, Dean of Brown University School of Public Health and a frequent commentator on the issues we're discussing today. Dr. Georges Benjamin will be testifying next. He is the Executive Director of the American Public Health Association, to which we all look for sound advice about public health matters. A special welcome from Austin to Dr. Kimberly Avila Edwards. She's at the Dell Children's Hospital as a practicing pediatrician, and she's the Director of Advocacy and External Affairs there. And I'd like to call Mr. Kind, who provided some good advice about a witness, to tell us more about challenges in rural areas. Ron?
Mr. Chairman, thank you for having this very important and timely hearing. The essence of what we need to do, get shots in the arm. But it's my honor to introduce the committee today from Wisconsin. Ms. Lewandowski is the Executive Director of the Wisconsin Immunization Network, WIN for short, where she builds successful community partnerships to address vaccine hesitancy and also access to vaccines, especially in our rural area. She's an immunization leader in Wisconsin and has worked to place equitable distribution to rural communities at the forefront of our state's agenda. She's also the Rural Wisconsin Health Cooperative Liaison to the Wisconsin Immunization Network and co-chaired the state's advisory committee on vaccine distribution. And the ranking member, Devin, may be interested. In addition to her work in Wisconsin, she's been recognized for extraordinary service in California for her contributions to the 2009 H1N1 influenza response. So, Ann, we're very happy to have you here today. We look forward to your testimony and your answers. Thank you, Mr. Chairman.
Thank you, Mr. Khan, and we look forward to your testimony. After we hear from her, we will hear from Dr. Reshema Ramachandran, I want to say it correctly, and she is a health services researcher, family physician, and National Clinical Scholars Program Fellow at Yale, and look forward to her insights. And now I want to call on our colleague, Ms. Miller, whose state has been doing rather well in getting shots into arms for the purpose of introducing an expert to tell us how it's done. Ms. Miller?
Thank you, Chairman Doggett and Ranking Member Nunes, for this opportunity to introduce my friend and fellow West Virginian, Dr. Clay Marsh. Dr. Marsh, we're so glad to have you here today. West Virginia has been leading the nation in vaccinating our citizens against COVID-19. We are often near and sometimes even over 100% of total doses that have been administered. This has been no easy feat and has been a success thanks to Governor Justice and Dr. Marsh. Dr. Marsh is West Virginia's COVID-19 czar, as well as the Vice President and Executive Dean for Health Sciences at West Virginia University. As a nationwide leader in the field of medicine, he has published over 140 academic papers and holds more than 20 patents or patent disclosures. Along with those achievements, he has seen our state through the pandemic and led us with a steady hand in ensuring West Virginia can recover and reopen safely. Thank you, Dr. Marsh.
And we will now begin hearing from our witnesses. I would ask you to summarize your testimony in 5 minutes or less. We have your written testimony. Given the remote nature of this for both for you and for our colleagues later, as the 5-minute mark approaches, I'll do a gentle tap that I hope you can hear from afar so that we keep our hearing proceeding along. So, Dr. Jha, would you lead off, please? Let's see if you, I believe you still need to unmute.
Yep, thank you.
There we go, great, I can hear you.
Perfect. Chairman Doggett, Ranking Member Nunes, thank you so much. It's such an honor to speak in front of your committee today. It has been a year since the virus that causes COVID-19 was first detected on our shores. And in that year, more than 28 million Americans have known to become infected, and more than 500,000 of our fellow Americans have perished as a result of this infection. This is such an immense degree of suffering that we as a nation have gone through, largely due to missed opportunities, missed opportunities to set up a testing infrastructure that could stop the spread of the disease, our failure to protect healthcare workers, these incredibly courageous men and women with adequate PPE, and more recently, our inability to vaccinate Americans as soon as vaccines became available. But things are getting better. We have 2 highly effective vaccines authorized, and I am very hopeful that today or tomorrow, the FDA will likely authorize a 3rd highly effective vaccine. Vaccinations are getting into arms and the numbers are rising. We are seeing drops in infections and hospitalizations and deaths. But we are not out of the woods quite yet, though we are making progress. So today I want to focus, as this committee is focused, on vaccines and vaccinations. In the time since Pfizer and Moderna vaccines were authorized, the rollout has been disappointingly slow and uneven. If we are to continue to make progress, we should understand what went wrong and what went right. And because vaccinations are driven by states, we need to understand the role of the federal government in this effort. The Trump administration invested billions of dollars into vaccine development and manufacturing. Those investments were very, very good things. But the Trump administration failed to pay adequate attention to what happens after vaccines are produced and delivered to states. Vaccines don't end up in people's arms by themselves. The states were largely unprepared, short on staff, with an exhausted public health workforce and no concrete plans for implementation. And unfortunately, the Trump administration did too little to help them. The messy rollout of vaccines only began to improve when, through congressional action, money started to flow to states. And over the past month, with congressional support and under the Biden administration, vaccine administration has started to improve. As of last night, roughly 91 million doses have been delivered and 67 million doses administered. About 22 million Americans, about 7% of all Americans, have received both doses. Far short of the Operation Warp Speed often repeated goal of 50 million Americans fully vaccinated by the end of January. With states left on their own, vaccine distribution has varied widely. States like Connecticut and West Virginia have fully vaccinated about 1 in 10 people. States like Iowa and Utah, about half that. Not surprisingly, some states are using up nearly all their vaccine supplies, and other states are keeping more than 1/3 of their doses on the shelf. And even within states, the distribution has hardly been even. The communities hit hardest by the pandemic, Black and Latino communities, are the communities least likely to have been vaccinated. At least that's what we know from the data we have. But unfortunately, we don't have very good data on this. About half the states are not fully reporting their data on who's getting vaccinated and who's not. Why have we done so poorly on equity? It isn't for a lack of good intentions. Beyond not having adequate data, we have created systems that are far too complex. Online portals to schedule vaccinations are difficult to access and navigate. They make it nearly impossible for someone without great digital skills to get an appointment. And when appointments do become available, they're often at times that essential workers can't make. We must do better. So how do we do better? First, we have to strengthen the state-federal partnership in public health. You know, the history of public health in America is that states lead and the federal government provides support. We must recommit to that partnership. Equity must be the reality and not just the aspiration. That means focusing on Black and Latino communities through pop-up and mobile clinics, engaging community leaders, and yes, collecting and publicizing data based on race and ethnicity so we know what's working and what's not. And I do believe, and I'm so thrilled about this hearing today, that we have to learn from successful states such as West Virginia and Connecticut and New Mexico. We will hear more from them, but as I understand it, having spoken to state leaders across the country, keeping things simple, accessible, easy to use is fundamental to that. You know, we are very close to the finish line with this pandemic. We have the evidence-based tools to get us there. Wearing masks, avoiding crowds, testing, and of course, getting Americans vaccinated. And as cases fall, we will be able to scale back these restrictions and bring this pandemic to an end and get our lives back. We have more than enough capacity to do it. The question is how quickly, and that is ultimately up to us. Thank you so much.
Thank you very much, Doctor. Dr. Benjamin?
Hi, good afternoon, everyone. Chairman Doggett, Ranking Member Nunes, and members of the subcommittee, let me just thank you for the opportunity to address you here today. Um, I know that many of my members have been directly engaged in the national effort to end this pandemic. But Mr. Chairman, let me first send my support and concerns for the people of Texas and the other states in the region are still challenged from the severe weather you recently had. As you may know, many of my members were both also impacted from the storm and are actively working to help your residents and people in the other affected states recover. So just wanted you to know that our thoughts and prayers are with you. You, of course, have my written testimony, so let me focus a little bit on this issue of getting shots in the arms equitably. Now, we know that wearing a mask, washing your hands, social distancing, and avoiding large crowds, as well as getting vaccinated, is the secret for changing the trajectory of this pandemic. We also know that getting these life-saving vaccines studied and approved expediently through the federal system with really full scientific transparency and rigor was absolutely a remarkable success. As she's pointed out, we also know that having a safe and effective vaccine and getting those vaccines into the arms of the susceptible population are two entirely different things. So as of this morning, we've administered over 68 million doses to people, with 46 million having received one dose and about 21 million having received the full 2 doses. But of course, despite this encouraging progress, we are still seeing troubling trends and disparities when it comes to who is being vaccinated, particularly in communities of color. One of the big issues about data by race and ethnicity remains an issue. And our nation just absolutely has to do a better job there. This is something that has really plagued the whole response from the beginning. But having a full and accurate record of the demographics of this vaccine effort is essential to ensure we focus more effectively on the populations who are most at risk. Now, the Kaiser Family Foundation has been tracking vaccine administration and have found these and documented these significant disparities in vaccination in both African Americans, Hispanics, Native Americans, and Asian Americans who compared to non-Hispanic whites. These disparities represent the impact of both vaccine hesitancy as well as vaccine access barriers. Now, in the area of hesitancy, we know that about 40 to 50% of the population have stated that they're not sure they'll get vaccinated. And as you know, these numbers have moved all over the place. And most of these folks are actually curious about the vaccine, but not anti-vaccine. They just don't know enough about it to get vaccinated. In our studies about communicating health information to these individuals, what we've understood is that messenger matters and the message matters. There are certain words and approaches that we think if one uses, they'll increase vaccine adaptation. So tailoring your message to the audience, because perceptions about vaccines differ by race, age, political party, and geography. Discuss the benefits of the vaccine as well as the consequences of not taking it. Find out and address what their specific concerns are and avoid judgmental language. Describing the vaccine development process, tell those folks what it does, what it doesn't do, what safety and side effects actually mean, and the ongoing safety precautions that are in place to track potential complications. Doing so, we think we can increase people's acceptance of the vaccine. We obviously have to deal with a range of disinformation and misinformation that's out in the community. You've already heard some of the issue about some of the structural barriers. Not having a computer, access to Wi-Fi or broadband is a big issue, not only for people getting appointments, but for our kids who had to stay home from school. Lack of a single point of entry remains a big problem, even though the CDC has the website Vaccine Finder. It also, because it takes you to your individual states, and that often remains confusing for many people. We just don't have enough telephone-based appointment systems, and language barriers remain a big problem. Limited number of available appointments, primarily due to the vaccine shortage issue, but also we need to make sure these appointments are available over extended hours and weekends. So, if all the vaccine appointments are gone during the day, if you're a bus driver or even if you're a doctor or nurse and you work shifts, you're not going to be able to get an appointment. We've got a whole range of logistical issues about where these vaccine sites are placed. So if you don't have a car, if it's not close to public transportation, or if there's not a health infrastructure, and that's particularly an issue in our rural communities. then there are challenges to getting vaccinated. You know, the equitable vaccine distribution within states continues to be a problem, in particular when you look at some of the vaccine redlining. Now, that's a term that some people have thrown around because we are seeing vaccine preferentially going into communities of affluence over underserved and communities of high COVID impact. Vaccine tourism, that's where people jump the line by going to different states or different communities to get vaccinated ahead of the resident population. Now, in some places where we have regional issues, like here in the Washington, D.C. area, it seems to be a relative trade-off. You know, the folks going into Maryland and then the folks coming from D.C. into Maryland are pretty much equal, but that's not always the case in all of our communities. The problem is when a group jumps ahead of the line and takes vaccine from one of the designated populations and in effect crowds them out from getting their shot. We also know that putting local pharmacies in communities is a good thing, except that many of them that are actually given the vaccinations aren't in the inner cities and communities where they're most needed. But some of the pharmacies are doing a range of innovative things to reach into those communities. And so we should applaud those efforts, but we should encourage all those pharmacies to do that. West Virginia, as you know, did that very, very excessively by looking at local pharmacies. And I understand we're going to hear from them today. Federally qualified health centers that are also in the community have the community trust. And finally, I just want to advocate for us rebuilding our public health system because we need a strong public health system if we're going to do this in the future. And I thank you for the opportunity for testifying with you today.
Thank you, Doctor. Dr. Avila Edwards.
Chairman Doggett, Ranking Member Nunes, Chairman Neal, Ranking Member Brady, and members of the subcommittee, thank you for the opportunity to testify today. My name is Dr. Kimberly Avila Edwards, and I'm a pediatrician by training with almost 20 years of experience in multiple roles, including serving the underserved in Central Texas. Ascension, Texas is a ministry of Ascension, one of the nation's leading nonprofit and Catholic health systems, with a focus on delivering compassionate, personalized care to all, with special attention to persons experiencing poverty and those most vulnerable. On behalf of Ascension, thank you for holding this important hearing. Our path forward on COVID-19 vaccinations has to focus on the most vulnerable and hesitant populations. We all know that there are many out there who will have to overcome significant challenges to get their vaccine, and some will have to be convinced to get vaccinated. These are the people we need to reach. They include the mother of one of my patients in clinic. I practice on a mobile clinic that serves uninsured children. Among our patient's family, one mother stands out. She's a hardworking cafeteria staff member in a local elementary school. She brings her daughter for every well check and every appointment for her daughter's asthma. Their family has limited transportation options, but we're able to bring her and her daughter to and from clinic using rideshare companies. Mom is very attentive to her daughter's healthcare needs, but does not have access to consistent healthcare to help and monitor her own diabetes. It is of the utmost urgency that she and many more like her receive a COVID-19 vaccine as soon as possible. Over the past year, COVID-19 has touched every one of our lives, though some have certainly been impacted far more severely than others. We have seen a disproportionate impact of COVID-19 on Black and Hispanic individuals, families, and children. The Hispanic community has consistently accounted for more of our COVID-19 deaths than their share of the Texas population. Of Dell Children Medical Center's pediatric intensive care unit admissions for COVID-19, 87.5 were Hispanic. There are many underlying causes for such disparate rates of infection and severe illness, and our data show that Hispanics admitted with COVID-19 experience significant challenges to health and well-being because of social impediments to health. For far too long, social determinants of health, such as income levels, geography, housing infrastructure, access to transportation, language barriers, and other drivers have been known to have a greater impact on a person's health and quality of life than even the clinical care they receive. But the pandemic has shown a spotlight on just how much these factors impact access to medical care and health outcomes. At Ascension, we're working hard to get everyone vaccinated, especially those who are the hardest to reach and most vulnerable. We've been developing partnerships with community-based organizations and bipartisan leaders who share our mission, piloting models for drive-through clinics, holding focus groups on hesitancy to learn what works, and working on other strategies to do our part. To address challenges in reaching vulnerable populations and reducing hesitancy, we're also partnering with trusted community voices, including physicians, healthcare workers, faith and business leaders, and public servants. These trusted voices can amplify accurate, authentic, culturally sensitive, and linguistically appropriate messages addressing hesitant populations. Now what we need is a predictable supply of vaccines. There is much more to do, and Ascension and Ascension Texas have the capabilities, community relationships, patient trust, and commitment to get the job done. We ask that you consider the following recommendations. 1, work with the administration to establish a national blueprint for states and health departments that outlines a set of consistent pathways through which healthcare systems can continue to partner and contribute to vaccination efforts, especially for those hard to reach. 2, continue the important work to improve the vaccine supply. Allow qualifying health systems to receive vaccine supplies directly from manufacturers. Establish uniform vaccine reporting standards. 5, ensure COVID vaccine trials include a diverse set of children of all ages. And finally, on behalf of our organization, I want to personally ask that each of you not lose sight of how deeply the pandemic has impacted children. It will remain critical for policymakers and healthcare providers to focus efforts on addressing mental and behavioral health challenges that have been exacerbated by the pandemic. Thank you again for the opportunity to testify today. Ascension appreciates your focus on ensuring the continued nationwide vaccine rollout is equitable, accessible, and successful for all Americans. We remain eager to continue working with you and with our state, local, and community partners to live out our mission. I look forward to answering any questions you have and want to thank Dr. Benjamin for his thoughts for my fellow Texans.
Thank you, Doctor, very much. Ms. Lewandowski, you may proceed.
Good afternoon, Mr. Chairman, Mr. Ranking Member, and members of the House Ways and Means Subcommittee on Health. My name is Ann Lewandowski, and I am the Rural Wisconsin Health Cooperative Liaison and Executive Director of the Wisconsin Immunization Neighborhood. I would like to thank Representative Kind and Chairman Doggett for the opportunity to be here today. The issues I am highlighting impact Americans regardless of their geographic locality, even while I address them from a rural lens. I am proud to represent a network of over 190 immunization coalitions that have worked to keep their communities free from infectious diseases for many years. No doubt many of us will continue to address vaccine access and hesitancy long after the much desired day that COVID-19 is no longer a national topic of discussion. The message I want to share with you today is simple, and it's been repeated by my esteemed colleagues. We must ensure the choice to be vaccinated is easy for all Americans. We must support this choice with funding for vaccine infrastructure and community relationships. The biggest challenge today is limited vaccine supply. The Wisconsin Department of Health Services reports that providers requested over 400,000 first doses for a vaccine this week. The federal allocation that Wisconsin received was 120,000 first doses. The message that vaccine remains scarce gets lost as federal policymakers discuss millions of vaccine doses over many months. Please allocate funds to create a federal communications task force to help the public understand continued vaccine scarcity. This task force should help federal spokespeople create consistent messaging that reduces confusion with the public. Finally, it can ensure that changing science is communicated effectively for the vast majority of the public who are non-scientists. Like many states, Wisconsin is rapidly approaching expanded eligibility for some essential workers. The most effective way to reach these workers is to bring vaccine to work sites, leaving primary care to continue to vaccinate those above 65. We must make sure these clinics are held on nights and weekends to accommodate non-traditional work schedules as needed. Community-based clinics should be easy to access. We can leverage data to determine the best location to place vaccine clinics. The data is expensive to purchase locally, but economies of scale make it relatively inexpensive to purchase at the federal level. For example, community data platforms estimates they can cover the entire United States for roughly $5 million. We can help all willing Americans get vaccinated by funding partnerships with faith groups, clarifying rules for mobile vaccinators, and using civic groups such as Rotary International, Alliance International, and the National Council of Negro Women. These trusted messengers will help us begin to address vaccine hesitancy. Vaccine hesitancy comes down to two key emotions: fear and distrust. These emotions leave communities vulnerable to misinformation that spreads much like a virus, according to data from the World Health Organization. These emotions do not listen to data or numbers. Facts don't matter when you're worried about your livelihood. If you distrust big government, you likely won't trust a vaccine developed with government support. If you distrust the government, you also likely won't trust it when government officials say you need to be vaccinated. It's really that simple. We overcome distrust by diving deep into communities. You've heard the impact of the message and the messenger. We need to find the community. We need to find the person that families call when they are in crisis. This is the best person to become a COVID-19 vaccine champion. They may be hesitant themselves, but the time we spend helping them understand the COVID-19 vaccine will pay dividends in the long run when it comes to vaccine uptake in their community. If we can coach them to understand vaccine hesitancy, they become the most cost-effective investment in vaccine infrastructure. The Ad Council has done extensive research on messages that motivate people. It comes down to our relationships with others. We know that caring for the neighbor who has heart disease, the woman battling breast cancer at church, and the diabetic friend are the people and relationships that matter and will motivate people to get vaccinated if they are hesitant. We do not need to add more statistics that use large numbers. People don't understand them, and frankly, they don't really care. We need the stories of hope. We need the stories of the woman who is asthmatic, who is worried about the vaccine, but says she will be vaccinated for her community. We need to talk about the things that bind us together, community, relationships, and coming back together in person. Thank you for this opportunity to speak with you today, and I look forward to your questions.
Thank you for your helpful comments. Dr. Marsh.
Well, thank you, Chairman Doggett, Ranking Member Nunes, and certainly Congresswoman Miller for your leadership and support and friendship for West Virginia. It is really a distinct honor to be here with you, and I want to thank also and congratulate the other witnesses who are testifying today for their good work. So I want to briefly overview our story in West Virginia, and just to remind this esteemed group that West Virginia going into the COVID-19 pandemic was rated by Kaiser Family Foundations as the most vulnerable state in the country. We had many health problems to overcome at baseline. And as we look at our response to COVID, I think this is really a story, as Ms. Lewandowski said, of culture and coming together and caring about your neighbors and caring about your families. It's not about being number 1, 2, 3 on a list. In West Virginia, we sought to do what Albert Einstein said, is to make complex simple. And we decided with the leadership of our governor that our target would be to save lives, to protect health, and to maintain the capacity of our hospital healthcare systems and their function as well as community function. And as we looked at our own epidemiology data, we recognized that the average age of a West Virginian dying of COVID-19 is 77 years old. 77.5% of West Virginians dying were over 70 years old, 92% over 60 years old, and 97% over 50 years old. As we looked further, we found that half of our deaths came from our nursing home population. So as we sought to understand how we could most quickly put shots in the arms of our most vulnerable people in West Virginia, we created a team of teams type approach that we call the Joint Interagency Task Force. This is a task force that's run by our best logistics experts and crisis management experts in our National Guard. We have 15 sectors represented around the table, and these sectors include healthcare, primary care, pharmacy, boards of medicine, FEMA, federally qualified health centers, and we task our leaders of our long-term care area with our pharmacy group to understand how we could best, most quickly get shots in the arms of our nursing home residents, which again accounted for half of our deaths. And they looked and said that the federal pharmacy program wouldn't work because of the rural nature of West Virginia. We had over 200 pharmacies, of which half were locally, privately owned. So we decided to go a different way and start a network of local pharmacies. Went to Operation Warp Speed, they agreed. And by doing that, we were able to immunize 85% of our nursing home residents, first shots by the end of December 2020, second shots by the end of January 2020. And we also then looked at our critical workforce and focused on those over 50 because of the epidemiology data we saw, and quickly then pivoted to our aged population over 65. To date, we've been able to immunize first doses of 160,000 of our 350,000 over 65-year-old West Virginians, and second doses of 80,000. And as a result of this, in 2021, over the first 7 weeks, we have seen a 85% reduction week to week in mortality, a 73% reduction in hospitalizations. We have seen fewer ICU patients and ventilated patients than we've seen since November. And we look at this event as a black swan event. So we know that we can't predict the future. So we have set up a rapid learning cycle. We have commander's intent. We know what we want to see done, and we do control vaccines very carefully and expect the vaccines to be used completely at the end of each week. But we give everybody in the state the ability to be creative and figure out how they can work in their communities to immunize their friends and families. And we know that we all shine brightest in the service to others. And we appreciate the opportunity to share our story here briefly. But more importantly, we are very proud to be part of this United States of America. And we hope to learn from everyone we can. And we're happy to share any lessons learned to help any other state care for their citizens the way that we want to care for ours. So thank you.
And thank you very much, and congratulations on the success that you've had. We're now going to move to the questioning period. Before doing that, I want to circulate and place in the record 2 documents that have either been sent to you or will be circulated to you. One is from AARP, just a letter that offers their views about the chaos in trying to get an appointment and their concern about healthcare disparities. And the second is the CRT Latinx COVID-19 research project, which was prepared by Ruben Cantu and the Community Resilience Trust in partnership with the Austin Latino Coalition led by Paul Saldana. These focus on some of the issues that our witnesses have referred to about the disproportionate impact on the Latinx community and the disparities in services between I-35 west and east, the highway that divides our community, and offer some comments about how to get more equity. I also realized that I have, well, first let me just say, without objection, those 2 documents will be included in our record and circulated, and if any other members have documents they wish to circulate, we will certainly want to add them in the record. But before we begin questioning someone I've been eager to hear, though slow to recognize, Dr. Ramachandran. Doctor, please proceed.
Thank you, Congressman. Chairman Doggett, Ranking Member Nunes, and distinguished members of the subcommittee, thank you for the invitation to testify today. My name is Reshma Ramachandran. I'm a researcher and a fellow in the National Clinician Scholars Program at Yale School of Medicine. I also serve our nation's veterans as a physician at West Haven Veterans Affairs Medical Center. I'm honored to testify before you today. My remarks reflect my own views and not that of my employers nor the organizations I work with. There's no doubt that the record-breaking availability of multiple safe and effective vaccines is an incredible scientific achievement. This would have not been possible without financial support from taxpayers whose dollars fueled government agency research and federal programs such as Operation Warp Speed. The Moderna vaccine, which is one of 2 currently available in the United States, benefited fully from this public support for its development and manufacturing. For several vaccine candidates, the American public has taken on the risk of creating these vaccines by not only paying upfront for their development and production, but also again for their purchase. Despite this, both manufacturers and the US government have left the American people in the dark on how their taxpayer dollars are being spent and whether access to these vaccines will be guaranteed. As a first step, Congress must make transparent exactly how much the public is investing in the development, manufacturing, and purchasing of COVID-19 vaccines, as well as the agreements that clarify the spending terms. Over the past year, Operation Warp Speed has repeatedly announced the allocation of billions of taxpayer dollars to individual vaccine manufacturers. Other government agencies, including the NIH, have also been granting funds and resources to these companies. These are worthwhile and necessary investments, but no comprehensive database exists of these expenditures. Moreover, access to these spending agreements has been incredibly difficult, with only heavily redacted versions being available after several requests and lawsuits. As a result, it is unclear who owns this publicly funded technology and whether the American people have any recourse should the companies face production delays, as we have seen repeatedly over the past months, or if they set excessive prices. Additionally, modified versions of these vaccines are now being developed to prevent against rapidly emerging, highly transmissible variants built on this publicly funded research. Clarifying who owns the vaccine technology and data through transparency of these agreements would inform whether the US government is able to help boost supply of the future adapted vaccines. One solution to ensure full transparency of both taxpayer spending and the conditions for this financing has been outlined by Congressman Doggett in the Taxpayer Research and Coronavirus Knowledge or TRACK Act. This bill would create a user-friendly public database of any agreements, as well as all federal funding across agencies for biomedical R&D related to COVID-19. In addition to transparency of taxpayer funds and terms, Congress should require all agreements with companies to include protections for patients to ensure adequate supply and access. These should apply not only to current vaccine candidates, but also to modified versions meant to address variants built on taxpayer-funded technology. All licenses awarded by the US government for publicly funded COVID-19 technology must be made open and non-exclusive. In doing so, the US government would be able to license vital data and technology, especially during a pandemic, to multiple manufacturers to meet demand. Moreover, Congress and the administration could require companies to share the vaccine technology and data to further boost supply and ensure access. One comprehensive approach would be to couple Section 1498 and full use of the Defense Production Act, as has been outlined by Senator Elizabeth Warren and Representative Katie Porter in their letter last month to the Biden administration. Finally, as has been narrowly included in a few contracts, Congress could also require reasonable pricing in exchange for procurement of doses. Manufacturers have repeatedly stated that they have set a lower pandemic price for these vaccines. Still, they are anticipating significant profit margins this year and have confirmed that prices will be higher in the future. While the federal government has been able to secure modest discounts, future pricing in COVID-19 vaccines will likely be problematic for patients, as annual doses will be needed and pandemic pricing will no longer be available. Lest we not learn from other vaccine markets, my research found that both public and private sector prices for the influenza vaccine rose over the past 2 decades, despite larger volumes distributed, multiple manufacturers, and several similar products being available. Such a pattern for COVID-19 vaccines of increasing prices would have significant implications on health spending, public health program budgets, and insurance premiums for those with private plans. My patients often ask me when they might receive the vaccine, as our leaders have had to make tough decisions, as we've heard about, to prioritize populations for the vaccine rollout due to limited supply. By safeguarding transparency and access, Congress would be ensuring a future our patients have already paid for, one of hope in being able to receive and afford this vaccine and no longer having to wait and be burdened by this devastating disease. Thank you for your time, and I look forward to your questions.
And thank you. And we will move on to questions. And let me begin with you. And I mentioned the TRACK Act, and pleased to have Senator Braun and bipartisan support for this measure. But what is it going forward if the price of vaccines continue to go up based on the flu experience? Why is it important for the public to have information about the investment it's made and the agreements that have been reached?
Yeah, thank you, Congressman, for your question. And that's a very critical question for us to answer now. The importance of us, looking at the experience of the influenza vaccine, what's happened in terms of price increases, has significant implications on the public health program budgets. As I mentioned, every dollar that we're spending on vaccines today and in the next few years in purchasing them are dollars that we won't be able to spend on other critical public health programs, as well as the recovery from this pandemic. In addition to that, the agreements actually outline whether or not the US government can lay claim rightfully to this publicly funded technology. And this has important implications now as we're seeing scarcity as being a hindrance for a number of populations from being able to receive the vaccine. And also in the future when we need access to future adapted vaccines meant to address variants. So I'd hope that Congress would be able to step in and act on the behalf of the American people to claim ownership of this technology that we ultimately funded and de-risk completely for companies. If this pattern continues, as we've seen with flu, likely what we'll see is that patients, even through their insurance premiums, will see this cost being reflected, and government plans will also have to take on the burden of paying more and more for this vaccine. Some companies have even said they would charge $150 or $175 per dose this past week in the next few years, which is exorbitantly expensive and would be billions of dollars for the government, but also for patients to be shouldering ultimately.
Well, of course, we don't have any information about how the prices were set either by the Trump administration or the Biden administration. If there is some limitation on price, isn't that likely to reduce the possibility that we will have the vaccine that we so desperately need?
I think, that's a great question as well. We actually have seen in a couple of agreements that the government was successfully able to include reasonable pricing provisions. This was after a number of requests, FOIA requests, Freedom of Information Act requests, and lawsuits. And so that shows us that it's possible for companies to work with the US government around things like reasonable pricing. The other part of this too is, we need to have also reasonable pricing in place, given that the public has already subsidized not just development, but also production, building these manufacturing facilities, and also advanced purchasing of these vaccines even before authorization. So we've really de-risked the process from bench to bedside, and it's critically important for the government to act on the behalf of the American people to lay claim and make sure that the prices are reasonable.
Thank you. Dr. Avila Edwards, we know, let me see if okay, I think it's unmuted now. We know that some vaccines are now either approved or about to be approved that do not have the efficacy above 90% that we saw in the first two. How do we overcome the perception, particularly in communities that have been overlooked in getting access, especially the Latinx, African-American communities, that they're going to only get kind of the second rate of vaccine, that they're being discriminated against in the type of vaccine that they get? What's the best way to deal with that?
Thank you for that question. So I think it's very important and very timely. What I like to focus on as a physician is that they are all effective. They are all keeping individuals out of the hospital and out not having severe disease. So I'm encouraged personally by all of the approved vaccines that we have, because which vaccine is right is so individualized, and there are so many multifactorial factors that go in to determining whether one dose is better than two doses if you cannot schedule that second dose or you have transportation issues. So again, the fact that they are all effective is what the message needs to be.
Thank you very much. And Dr. Jha, you discussed the issue that I raised with the Vaccine Injury Compensation Modernization Act that I'll be introducing in your written comments. Could you just comment briefly on the importance of having an effective and just vaccine injury program as a tool to address hesitancy?
Yes, so Congressman, thank you for that question. And absolutely, one of the successes of the vaccine programs that we've had over the last decade has been this vaccine injury program, which has compensated in a no-fault mechanism to people who have suffered injuries. It's been open, it's been transparent, but it needs to be modernized. It needs to be brought up to 2021 standards. Currently, the COVID vaccines are actually covered through a different mechanism, which raises the bar and makes it more difficult for people to get compensation. I really believe that, first of all, the COVID vaccines should be covered through the VICP, the Vaccine Injury Compensation Program, not the CICP, the Countermeasure Injury Compensation Program. But the legislation you have introduced, which would expand the number of masters who make the determination, make the program more accessible, easier, I think would go a long way to both compensating people who are injured, because even though these vaccines are extraordinarily safe, they're not 100%, because nothing in life is 100%. And the truth is that there will be people who will have some reactions or even injuries from these vaccines, and they should be compensated. But as you suggested in your question, that will also build confidence in the process and allow, I think, more people to feel confident about getting the vaccine. So I think those are very important steps forward.
Thank you so much. Mr. Nunes?
There we go. Sorry about that.
No, just wanted to be sure you were there.
Yeah. Thank you, Mr. Chair. My question's for Dr. Marsh. As I discussed in my opening statement, California is having a rough time of its initial vaccine distribution rollout. According to the CDC, California has used only about 60% of its allotted vaccine doses, ranking in the bottom third of all 50 states, while some areas in my state, such as San Francisco and Long Beach, have been able to vaccinate eligible residents. Governor Newsom's distribution plan has left behind areas such as my district in the San Joaquin Valley. For a state that is home to Silicon Valley, it is depressing to see California leave behind citizens who are struggling to access and navigate the sign-up process. Last week, several of my colleagues from California Republican delegation sent a letter to Governor Newsom demanding answers on how they are determining vaccine allocations to counties, healthcare providers, and pharmacies, as well as asking how many doses are awaiting distribution in the state of California. Dr. Marsh, given the success of West Virginia's vaccine distribution process, what advice do you have for California to reverse this flawed vaccine rollout and get more Californians inoculated?
Well, thank you, Congressman. I would be hesitant to render any opinions about any state, and certainly California is a very complex state relative to West Virginia. But I do think that simplicity of intent is very important. So once you understand what the goal is, it's easier to achieve it. I think that having a top-down versus meets bottoms-up approach to vaccine distribution is very important. We have been very intentional about controlling the flow of vaccine into the state. We have 5 hubs that bisects the state so that we can receive vaccine in a close distance to any site in the state that we decide to vaccinate. We allocate just-in-time amounts of vaccine. We're very disciplined about the target group, the priority groups that we will allow people to vaccinate. But then we are very much in favor of every one of our locations, which are located in all 55 counties, at federally qualified health centers, at hospital-based clinics, and at some pharmacies, to be creative in the way that they deliver vaccines. And we've had stories of people that drive to a person's house who's not able to get out to vaccinate them. And these are really West Virginians taking care of each other. So I do think simplicity of purpose, management of vaccine, constant watching of making sure that no vaccine goes to waste and no vaccines are left on the shelf. I think those have been important parameters for us.
Thank you, Dr. Marsh. And where do you stand now with your vaccination goals? Are you where you expected to be? When do you expect to kind of meet your threshold?
Well, thank you, Congressman Nunes. We very much want to finish our over 65-year-old population, and we believe with the additional vaccine doses that we are starting to receive, that we can accomplish that in the next month. We then will pivot to our medically complex patients, and we will also start to look at some of our over 16-year-old population who have particular problems like Down syndrome, who had solid organ transplantation, who have acquired or who have congenital problems that require caregivers. And we have other categories as well that we hope to roll out soon. But our focus will continue to be to save lives. And we believe the faster that we can put at least one shot in the arm of our most vulnerable population, the better we'll do, and the more that we will keep the viral variants from becoming a big issue in West Virginia.
And the new Johnson & Johnson one shot, if that does indeed get approved here, when do you think that one will be on the market from what you're hearing?
We hope that if this gets FDA approved and if the Advisory Committee for Immunization Practices gives their perspective, then we should see vaccine next week, we believe. And if we get that vaccine, our hope is that we'll use that in our same vulnerable population. As was mentioned, we believe that the protection against severe side effects, death, hospitalization is really the critical determinant of the allocation.
That's great. Well, Dr. Marsh, thank you for coming in. I want to thank all the witnesses today. And Mr. Chairman, I'll yield back.
Thank you, Mr. Nunes. Mr. Thompson?
Thank you, Mr. Chairman, and thank you to our excellent panel of witnesses for being here today. It sounds like we all agree that getting shots in arms is our #1 priority right now, and getting businesses back open and kids back in school and ending this unprecedented isolation, getting people vaccinated is the irreplaceable first step towards whatever normalcy is going to look like. And so I'd like to start my questions there. And I have a question for Dr. Jha. You raised a number of points I'd like to ask you about, but I'll start with the big picture question. Right now, you mentioned that roughly 19 million Americans are fully vaccinated. Do we have any sense, or is there any consensus on how many Americans need to get fully vaccinated in order for us to start returning to pre-pandemic life? Is there a critical mass we need to reach? 300 million people, 320? What should we know?
So Congressman, fabulous and probably one of the hardest questions in the pandemic right now.
You can do it.
So there is what is the herd immunity threshold? And there is some disagreement among scientists, but we think it's probably in the 75 to 85% range, which gets us into the 250 million plus Americans. But we don't need to get to herd immunity just through vaccinations. There are two things to remember. One is probably about 85 million Americans have been infected with the disease. We only identified 28 million, probably another 50, 55 million Americans have been infected and are not aware of it. So we already have quite a bit of population immunity. The bottom line is once we get above 50, 55% of Americans having population immunity, infection numbers will come way down. Many things will start becoming quite safe to do, even if it's not fully back to herd immunity and life kind of a new normal. So I see this as a glide path towards a new normal. And I really expect that by the time we get into the summer, a lot of things that we value, a lot of gatherings will start becoming quite possible and safe, certainly among people who are vaccinated. There's a bit of a cyclical nature to this virus, so we're gonna have to deal with the next fall and winter. One of the reasons I think a lot of us worry about making sure that people have confidence in the vaccines is if we end up with only 60 or 70% of people vaccinated, we're gonna have a really tough next winter. Because the virus will come back. There is a seasonal component to it. And so one of the things that we have to focus on is also that long term. But I think you should see the economy really starting to do much, much better as early as this summer.
Thank you. And then another question for you, Dr. Jha. I want to ask about a growing concern in California related to new strains of COVID that's emerged over the last couple of months. And by the end of this month, or by the end of next month, experts predict that this strain will account for over 90% of the new cases in our state. And the initial signs are very troubling. It's more transmittable, more harmful to the body, and significantly less responsive to existing vaccines. Can you just let us know anything about the risk posed by these new strains and what we should be looking out for and what we should be worrying about?
Yes, absolutely, Congressman.
Do we need to do something different because of these?
Well, so it's first of all worth understanding that new strains and new variants come about when you see large outbreaks. Large outbreaks basically give the virus a chance to have more mutations. And so basically we're pushing our luck every time we have large outbreaks because more variants will come up. And one of the reasons why many of us have been calling for trying to keep the virus levels as low as possible is that it gives the virus fewer opportunities to mutate. Now, to your specific question around the California variant, we're learning still about it. There's new data about a potential new variant in New York. We're going to see things like this. So far, we have not seen any data that I'm aware of that any of these homegrown variants or even any of the international variants make our vaccines totally ineffective. They may make it a little bit less effective, but these vaccines are just really impressive and still going to hold up, I believe. And the single biggest thing we can do to deal with these variants is suppress the virus and get lots and lots of people vaccinated quickly so that we stop giving the virus more and more chances to mutate. It mutates every time it infects new people, it has the opportunity to. And our best strategy here is vaccinate quickly, suppress the virus, and we get our lives back.
Thank you very much. I yield back.
Thank you. Mr. Buchanan.
Thank you, Mr. Chairman, and I want to thank all of our witnesses today. Obviously, Sarasota, Florida, my region, we have 225,000 people 65 and older, so it's very critical we get the shots in the arm sooner than later. I did want to mention one thing before I get into questioning. I toured one of our facilities, the public health facilities that they've used. They're administering 2,000 shots a day. Very impressive, because one thing I didn't realize, half of the workers or more were volunteers. So it's nice to see the community come together, and I'm sure a lot of other communities, everybody understands the significance of this. Dr. Marsh, I wanted to ask you, you've had quite a bit of success. I know West Virginia is a smaller state compared to some of the other states, but one of the things I found in business over the years, and we had offices, 15 regional offices, originally out of Michigan, but in California and everywhere. And I found that true in most of my business career. I'm a big, big believer in decentralization. We look at the federal government, and there's certain things they can do, but it seems at the end of the day, the success you have or other states have is going to be a lot in terms of the governor and the local leadership and people working together. Not to say the federal government doesn't provide resources and CDC and other things, but I wanted to get your thought on that, because they can also give us best practices. Trying to manage 350 million people compared to individual states, to me, it's a big deal. And I think I applaud West Virginia for what you've done. What's your thoughts on it?
Well, thank you, Congressman. You know, certainly, as I mentioned, our approach is a bit of a top-down meets bottoms-up, but I think a key success factor for us has been that we are very disciplined with the allocation of the vaccines to our hub sites and to those spoke sites that then focus on the targeted populations that we are committed in our priority scheme to approach. But we absolutely want the sites that are administering the vaccinations to have that flexibility so that they can work within the scope of their own community, their own population, so that they have lots of freedom and flexibility to be able to be creative. And in fact, what's really fun about that is we've gotten a lot of feedback, and we've continued to iterate our approaches at different hub and spoke sites based on the feedback that we're getting from some of those that then share with others.
And let me ask you, because schools across the country is a big issue. You seem like pretty much at every level, kids are back in school, minimal risk. I'm sure there's some, but minimal risk in terms of in-person learning. I assume they're back in school 5 days a week from K to 12 and universities. Is that what's happening in West Virginia?
Well, thank you, Congressman. So what we've done is looking at our own epidemiology data and working with Dr. Emily Oster from Brown University. We have determined with our governor that pre-K through 8th grade will be in session for 5 days a week, and we are appropriately focused on the mitigation measures to protect people in the classroom. But because of the difference in the national data around the spread in classrooms, that pre-K through 8 has a substantially lesser transmission rate in classrooms than it does than in the communities. But high school has the same rates in the classrooms as the communities. We are then tethering the high school in-person attendance to the community rates, and we've seen those dramatically go down in West Virginia as well. And we do have higher education classes in all of our colleges going on, and of course, we're tracking those carefully.
And one last question, how would you, in terms of additional funding that we're going to provide here probably shortly in the near future, how much of an impact will that have for you to get that additional funding to be able to get where you need to be, where you want to get quicker?
I appreciate that, Congressman. I mean, certainly, we have many people in our state that that are suffering, and additional funding will help them. But related to the pandemic response, the further and accelerated production of vaccines are critical for us. And then having the ability to continue to grow the infrastructure so that as those vaccines come to bear, we will be able to quickly turn those into vaccinations. So
Thank you very much, Mr. Kind.
Well, thank you very much, Mr. Chairman. And listen, I want to thank our panelists for their excellent testimony here today. But Ms. Lewandowski, let me start with you, and thank you again for your testimony and your availability. But I noticed you didn't toot your own horn for your opening, but after the initial stumble out of the block in Wisconsin, I think we now rank in the top 5 of states when it comes to getting doses in arms once we receive those doses. So just want to thank you and the Wisconsin Immunization Network for all the hard work you've done to turn that on, the success rate. Let me ask
Higgins, and he's not here, so that helps a little.
Let me ask you, given your work in the vaccine hesitancy area, that while the
Is that
numbers
your understanding that he's still not here?
point in the right direction, meaning down, we still, Mr. Chairman, I don't know if someone's muted. Can we,
I'm just looking down the list to
get
see if
everybody
it's on.
please?
I think it's the chairman.
Yeah. Mr. Chairman,
Sir.
thank you.
Thank you very much. Let's see, Mr. Adrian Smith.
Mr. Chairman, you're not muted.
Okay, thank you.
Okay, thank you. And back to you. Hesitancy. While the numbers nationally seem to be getting better, we still have a challenge in rural America. Why is that? And do you have one or two top recommendations of what we can do to have that trust and confidence in rural America too?
Yes, so as I mentioned in my testimony, these are complex issues. Rural America is diversifying. There are Hispanic populations that we need to be able to reach with accurate and culturally sensitive messaging. But we also need to understand that many of our rural communities have felt left behind. And this COVID-19 has been yet another opportunity for us to leave them and sort of ignore their needs. And so we need to make sure that we know that we see them, we hear them, we invest in them. If we are demanding that rural communities need to go online to receive a vaccine appointment, that they have access to the broadband. As my esteemed colleagues mentioned, there is not health infrastructure in the rural communities, so we need to be bringing vaccines to them. In our experience and the data that we see in rural Wisconsin, the farther you are from a vaccine access point, the less likely you are to be vaccinated. And so if we can start to bridge that gap with mobile vaccine clinics hosted with trusted community messengers who are able to go in and say, this is something I'm doing, I've done it, it's okay. these are strategies that we can use to make sure that even our rural communities have confidence in this vaccine.
Yeah, and with that, Mr. Chairman, Dr. Wenstrup and I had just sent a letter to the administration's COVID task force telling them that if they're going to be stepping up this federal information campaign, let's not forget about the rural areas. Let's make sure we're investing that information in rural media markets, trying to get local rural validators involved too, where there's greater trust. So I'd ask unanimous consent to have that letter inserted in the record at this time, Mr. Chairman. And Ms. Lewis, one other issue. I feel as if, maybe I might be wrong, but underutilizing primary care physicians as far as patients going to them for information, for signing up for vaccinations, knowing where to go, and getting that information included in the electronic medical records, which I think is another glaring gap that's developing here. Are we using primary care physicians enough, given that roughly 75% of the population has a primary care assigned to them right now?
So I think that's a very complex question. I think it's an excellent one. I would point out that in Wisconsin, we have a very wonderful Wisconsin Immunization Registry. And so this registry is required to be used by any immunizer. And so as they immunize, that will go into the registry. Occasionally, there are challenges with interoperability with medical records, but all providers who are providing vaccine should have access to that registry. I think right now the issue is vaccine supply. And so primary care models are not receiving as much supply as they could. And so we're underutilizing all of our providers. As I mentioned, we had a request for over 400,000 vaccines this week, and we only have 120,000 coming in our federal allocation.
Great. Well, thank you. Chairman, I yield back. Thank you.
Thank you, Mr. Kind. Mr. Adrian Smith?
Thank you, Mr. Chairman. Thank you to all of our witnesses here today. Your perspectives and expertise I certainly appreciate. And obviously, this is a very timely discussion. It's hard to imagine how far we actually have come. And I think it's just amazing that after only 1 year, not only are we on the cusp of 3 vaccines having been approved to fight the pandemic, but we have already administered over 66 million doses and counting, obviously. I appreciate what the previous administration, the Trump administration, did, and even so incredibly amazed at the private sector and the incredible talent and innovation of the American vaccine manufacturers. That here we are with an opportunity to start thinking post-pandemic. I don't want to rush out there too far, but I am glad that we are making progress. So as vaccines are being rolled out across the country to ensure that those on the front lines are protected, and certainly those with the highest risk of COVID complications, that they are also protected. So I'm glad again that we're making progress. One of the most impactful I think measures for our economic recovery, and more than just economics too, but recovery for our country, is the reopening of schools for traditional in-person learning. I'm glad to say that the schools of my own congressional district in Nebraska have been excellent examples here. Many of them are already operating fully in person, and I have to say that that's done for the great benefit of the students themselves. So we've known for months now that depriving students of in-person instruction actually puts them at a very serious disadvantage for both learning and I think what many would consider necessary socialization. A recent assessment of online versus in-person learning by middle and high school students at a large school district in Nebraska found that the percentage of online-only students failing 2 or more classes to be over 3 times higher than those physically in the classroom. The CDC has made it very clear that in-person learning can be undertaken with risking increases in COVID transmission without risking increases in transmission, so long as certain basic precautions are taken. There's even, I think it's important to note, there's even $64 billion in unspent, already appropriated funding for K-12 schools, which is currently waiting to be used in safely reopening schools. And actually, the 64 billion does not even include the efforts currently underway as I speak to add to the spending. Yet many school districts, especially in very urban areas, are still absolutely opposed to bringing their students back into the classroom. Dr. Marsh, like Nebraska, West Virginia has seen a significant number of schools returning to either hybrid or fully traditional in-person instruction. Do you think it's possible to safely reopen schools before widespread vaccination has actually been completed?
Well, thank you, Congressman. Certainly looking at our own epidemiology data, we saw very little spread in classrooms. Where we saw spread was people coming from the community. We did see some spread on sports teams. The only spread between students and adults were in special education classes where students weren't wearing masks, or in music classes where people were singing or playing a wood or a brass instrument. So we believe that the schools are safe. Again, we're working with Dr. Emily Oster, looking at the North Carolina data showing really no spread between students and teachers during the last school year in 2020. So we have offered our teachers over 50 years old and school personnel, service workers, vaccination as an extra precaution, because again, our epidemiology data suggested that 97% of our deaths in West Virginia are in people over 50 years old. But we did not think vaccination was required to bring the students back to class.
Would you have any advice that you would offer schools, maybe 2 or 3 top priorities that you might recommend, given your perspective?
Well, certainly, looking at the epidemiology data in the schools, make sure the schools are undergoing good mitigation practices as outlined by CDC and others. And then I think that, working and making sure that you're tracking these schools very closely to make sure if there are any outbreaks that you're immediately investigating them so that people do feel safe there. But otherwise, we know the benefit for the students is significant. And we know from a long-term perspective, if you have students that don't finish college, particularly in rural states like West Virginia, they have a susceptibility to lower life expectancies and earlier deaths and much more problems with addiction-related problems.
All right. Well, thank you very much. I do appreciate your expertise and insight, and I yield back the balance of my.
Thank you. Mr. Blumenauer?
Thank you, Mr. Chairman. And I appreciate you assembling for the committee the range of expertise here to help us do a deeper dive on the aspects of vaccination, the various approaches that have been taken. It is informative and it is something that I think we all want to do our best to understand how to take advantage of the opportunity of the vaccine development. I must say, I have been no fan of the previous administration and being asleep at the switch and losing 500,000 people, wildly disproportionate to any other country in the world, especially one that is as rich and powerful as the United States. But we have had remarkable success, I think, with the development of the vaccines, and I give them credit for that. I'm sorry there was no good coordinated plan in terms of how we get them into the arms, but you are all working to be able to fill that gap. Mr. Chairman, I guess the one question that I would pose to our panelists deals with this success of these, now it looks like 3 vaccinations that going forward, and the difference that we face with the Johnson & Johnson. It has different characteristics, different time frame, and I'm wondering if we have any suggestions from you about if we're going to have 3 vaccines available with these different characteristics. How do we communicate to the general public so that it doesn't raise more questions? We've already seen some examples of really weird behavior of people trying to intervene and stop vaccinations. Some people are a little leery. I'm hearing this at home from people that I don't think should be quite this apprehensive. And now with 3 choices and the different characteristics, I would really value your advice and counsel about how you would suggest we approach communicating this with the general public. And I would ask any of the panelists for brief responses. I'd like to hear from several of you if time permits. Somebody jump in.
Hi, Congressman. Thank you. This is Dr. Benjamin.
Yes,
You
sir.
know, for many people, assuming the J&J product gets approved as we believe it will, you know, taking one shot is quite convenient. And I think we've got 3 products. They have different attributes, but people make decisions about multiple products all the time. And I just think we have to tell people that, first of all, take what's available to you, because getting vaccinated now is more important than waiting to what might be available in the future. And again, for many people, particularly people in inner cities and communities where, you know, taking off work is a challenge, getting that one shot with an effective vaccine that's going to certainly protect them from getting very sick or dying should be a high priority. And I think we can share that with them. And the fact that now the Pfizer product is been approved for an easier storage in refrigerators, I think will make that product even more available to communities.
Great, thank you. Other thoughts about how we communicate this, Dr.
Well,
Schaub?
yeah, so let me just very quickly say, to me, they really are 3 superb vaccines. And I personally, and I've been communicating this to the public, I've been very clear that I would take any 3 of them. I've already got mine, so I'm not gonna get another one. But certainly with my family, I've been very clear that people should get whichever is available. And people like to focus on that headline number of lower efficacy maybe for the J&J. And I remind them that the J&J vaccine was tested in a different population. It was tested in South Africa and Brazil. Moderna and Pfizer vaccines were not. And they were tested with the new variants and did superbly well. And there were no people who got hospitalized or died from the variants with the J&J vaccine. So, boy, I'd be hard pressed to know which one I'd pick if I had a choice de novo. And what I tell people is, if you can get a vaccine that's authorized by the FDA, get it.
Ms. Zdrowski, do you have thoughts on this?
I would simply my colleagues that one vaccine is fantastic. It's easier to get. Highlighting that it was tried against the variants, something that the other vaccines were not. So we actually know those numbers, and particularly the numbers that no one was severely ill or died are critical pieces of information. But I think the top line message needs to be, get whatever vaccine is available to you in your community that it fits your life, fits your schedule, so people can't come back.
Great, good advice. Thank you very much.
Thank you very much.
Thank
Mr.
you.
Reed? Mr. Reed? All right, how about Mr. Kelly?
It's Jason Smith.
Okay, then I believe Jason Smith.
Thank you, Mr. Chairman.
Thank you. Please proceed.
Thank you. It has been a long and difficult year for many Americans, but the worst is behind us. Because of President Trump and the brilliance of Operation Warp Speed, we are on a path towards herd immunity less than 1 year after the beginning of a once-in-a-generation pandemic. 13.9% of Americans have already received their first dose of the vaccine. Over 64 million doses have been administered thus far. It is a truly remarkable achievement. The Biden administration inherited a robust vaccine program from President Trump, and what we see happening today would not be possible without the contracts he negotiated. Dr. Jha, I found your testimony that President Trump failed to make adequate investment in distribution infrastructure or to support states' efforts to do so in June, once we saw promising data on the Pfizer and Moderna vaccine to be disingenuous. I'm sure you are aware that this vaccine was developed in record time, and the average vaccine takes 5 to 10 years to develop. I'm sure you're also aware that President Biden was expressing concern with any promising vaccine under development as recently as September, significantly undermining public trust. I hope this helps you to understand the irony of your criticism. In terms of opening the economy, I'm extremely frustrated by the current administration's pessimistic and often contradictory approach. Dr. Fauci's messaging especially has been downright damaging. He has said continued public health measures for vaccinated individuals would only be necessary if the vaccine was on the low end of effectiveness. The vaccines currently available are over 90% effective. More importantly, they are nearly 100% effective at preventing hospitalizations and death. Yet Dr. Fauci still discourages those who are vaccinated from visiting restaurants or seeing family. For comparison, the swine flu vaccine developed under the Obama administration was estimated to just over 50% effective. The effectiveness of the COVID vaccine combined with data from Israel showing that if you are vaccinated, you're not spreading the virus raises the question, why does the Biden administration continue to tell us we will not return to any semblance of normalcy until 2022? The answer is clear. This is all political. The public health emergency provides Democrats with an excuse to push a series of progressive wish lists on the American people. The administration knows it is safe to reopen the schools, yet they are beholden to the teachers' unions. They know that it is safe for a vaccinated individual to eat at an indoor restaurant or visit family, yet this undermines their narrative of their control. A lot of the folks I represent back home in Missouri are already hesitant to get the vaccine. And if we continue to tell them it is not the key to return to normalcy, what incentive do they have? 31% of Americans are waiting to see if the vaccine is working before taking it. Another 13% have definitely said they will not get it. Without public trust or the desire to get vaccinated, we will never reach herd immunity. It's essential that fear-mongering and pessimistic messaging ends. The United Kingdom has announced all coronavirus restrictions will be lifted by June of this year. A study by Columbia University found that we could reach herd immunity by May of this year. In my opinion, the current timeline to reopen the economy that this administration is operating under is not ambitious enough. Dr. Marsh, can you please comment on the data coming out of Israel showing the vaccine is in fact preventing virus spread?
Thank you, Congressman. Yes, there is, I think, evolving data to suggest that people that do get vaccinated with the mostly with the Pfizer vaccine in Israel, but that the fully vaccinated folks have very little problem with persistent infection or infectivity. I do understand that this is an evolving set of issues, and as I said before, that we're constantly learning. And but I think that the data does support what you are saying about that. There's less concern today from the data that at least I'm aware of that people might be able to express virus after full vaccination.
Thank you. Your time has expired. Ms. Sewell, and Ms. Sewell, if your time permits, perhaps you can permit Dr. John opportunity to respond.
Thank you, Mr. Chairman. I want to start by thanking you and the Health Subcommittee staff for putting together today's event. This has been really, really informative, and I want to thank the witnesses for being here as well. I can think of no bigger challenge for us as a Health Subcommittee than to help figure out a way that we can make policies to reverse the trends that have made communities like I represent the most at risk for chronic illness, as well as COVID morbidity morbidity, to make sure that they are addressed and we beat this pandemic, crush this virus, and get the economy back to what we to normal, as well as to make sure that our kids can go back to school and that we can all be productive. When I thought about COVID-19 pandemic and the vaccination challenges that we're facing right now, I think often of one particular constituent of mine, Pamela Rush, who died of COVID-19 last year. She suffered from diabetes and heart disease, along with a myriad of other chronic conditions. She lived in a county with no hospital, a rural county in my district, and that county only had one primary care physician. Nearly every single indicator of poverty in America found its home in Pamela Rush. What keeps me up at night is the knowledge that for nearly every one of her issues, political will has stood in the way for us to find solutions, bipartisan solutions that could have saved her life. Both being Black and being in a rural area are more likely than white and urban counterparts to die from COVID-19. Since the start of COVID-19, as of yesterday, in my home state of Alabama, 9,831 Alabamians have died. And according to the recent data, approximately 50% of the cases account for the 14 counties that I represent. That means that we have a lot of challenges, sir. Mr. Chairman, I would ask unanimous consent to enter into the record this Bloomberg article from February 25th entitled, "A Black Neighborhood in Alabama Has Yet to Get a Single Vaccine Dose."
Thank you. Without objection, it is so ordered.
Alabama ranks second to last in the percentage of people receiving at least one COVID vaccine. We can and we must do better. This includes focusing our attention on the systemic inequities in our healthcare system that have only been made worse by the COVID-19 pandemic. As our nation continues efforts to combat COVID-19, it's imperative that we focus on ways to bolster the effective and equitable distribution of the rollout. It was really very important for us to have this hearing today and to hear from our experts. I'd like to ask a question to Dr. Benjamin, the Executive Director of the American Public Health Association. Dr. Benjamin, we know that the hardest hit populations are in underserved and unaccounted for areas that are mostly communities of color. According to the Alabama Public Health Department, as released in their weekly report, Black people in my state account for 17% of the received vaccinations, even though we make up 27% of the state population, while white counterpart in our state, 80% of them receive vaccinations, and they make up 68% of the population. So, Dr. Benjamin, your organization has identified the critical role communication plays in urging vaccination adoption across different population groups. Can you talk to me about how technology can be used and trusted community leaders can be used in order to spread the word and to get legitimate concerns about vaccination hesitation in communities of color? Alabama, given the Tuskegee experiment, there is a large fear of that in my particular state and in my particular district. But how can we use technology solutions like survey platforms and text-based pulse surveys and other things to help us with this challenge, acknowledging that we also have a challenge in most of these areas, infrastructure-wise, with broadband? I do want to understand how we can get not only the use of technology, but the use of more broadband as a solution to part of the problem.
Well, let me just say that it is very important for Congress to support our nation dealing with these broadband deserts. I think that's an absolute clue that we have to do, and not just for health, but for education. As you know, the Ad Council just rolled out, just the other day, a new ad campaign called "It's Up to You." We've been a part of that campaign, and it is, at least the first initiative part, is focused on communities of color. And we went out, we talked to people in communities of color, and we're using people who are culturally competent. We have ads, we have social media texts. We are using literally both a air game and a ground game to reach those communities I think the most important part of that campaign is using people that people trust. Now, nobody knows me, but if I can influence people that are in the community, leaders of faith. So we've got several leaders of faith in those communities that we're trying to give the information to, so that they can, basically preach from the pulpit. And of course, many of them are doing it just as we are doing now on Zoom through remote education. And so getting our leaders of faith to do that is going to be very important, getting sports figures, et cetera.
Absolutely. I know that my time is cut short, Mr. Chairman. I just want to say for the record that I think that it's critically important that a lot of the strategies that we're talking about today get implemented across the nation. I think a national strategy on dealing with inequities with the vaccination is something that is critically important, not only for communities of color, but for rural communities as well. Access is a problem, Mr. Chairman, and we have to do better in making sure that we provide funding for mobile units, that we provide funding for broadband, that we actually encourage these mass testing sites and the use of federal efforts like in other states, in some states with using National Guardsmen to help to roll this out. We can't do enough to make sure that that we have an equitable distribution of this vaccine in order to curb and crush this virus. Thank you all.
That's certainly right. Mr. Schweikert.
Thank you, Mr. Chairman. And actually, in an odd way, some of my questions are actually going to dovetail to Ms. Sewell. First off, one of the little side math projects we were trying to do in our office is understand the populations that we're being told are under receiving the vaccination, at the same time looking for some data on populations that are vaccine skeptical. If I was to turn to the panel and say, where can we go to find quality, not a document talking about who we want to communicate to or are culturally credible communicators, but first some data facts. The reality of it is Arizona may be the most urbanized state in the country. My congressional district is urban, suburban, so I don't particularly know the facts of dealing with states that have lots of rural communities. But I'm looking at our numbers, and our numbers look substantially different than other states. Is that because we're in an urban, suburban environment? So first question to the panel. If I came to you right now and said, I just need the best factual data on populations that are first vaccine skeptical, where would I go? Anyone want to step up and take a shot at that?
Sure, Representative, I would recommend that you visit the Kaiser Family Foundation. They have been extremely good
well, can I forgive you? I'm going to ask you to speak up as loudly as you can.
I'm so sorry. Congressman, I would recommend that you visit the Kaiser Family Foundation. They have been instrumental in providing very good data.
Actually, believe it or not, that binder is sitting right here on the side of it.
Yes. So I would use them. They present it very wonderfully. It's in tables and as much data as you would like to find.
And my reason for a little bit of focus on this, Mr. Chairman, is in one hand, we will take a shot at a state, Texas, Arizona, wherever it is, and say, well, not enough of my Hispanic population is receiving the vaccine, but then you need to look here how much of that same population may have a cultural barrier or a skepticism barrier that also is an additional barrier to getting that person into getting that stick in their arm, and understanding that some of these numbers have other levels of complication that we need to deal with. Also, Mr. Chairman, with your permission, I'd like to actually submit a couple of articles to the record. An article from Arizona,
Yes.
Florida, in regards to the distribution model, reaching out and working with ride sharing to get those that have some transportation issues as a community good. In Arizona, we're actually using a project privately funded with the Salvation Army acting as the coordinators, with Uber using their social good fund to actually get those who have some transportation issues to actually some of the massive vaccination sites. And my understanding is the same project is being done with Lyft in Florida. But I want us to sort of think a little bit more broadly than our typical, sometimes partisan talking points, that there are some of these creative ideas out there on how do you reach out to a population? Do you immediately say this has something to do with them being discriminated against? Are we dealing with more cultural sensitivity issues of comfort? And can we do a better job in understanding that? And is it Anne? Help me pronounce your last name.
Lewandowski, please. Lewandowski, please, sir.
But you spoke to it on how we must communicate to diverse populations and when we're getting there. And then can we use technology, as Ms. Sewell and some of the others spoke about, community ride sharing, some of the other ways you get populations that may not be as mobile. So I'll get those articles submitted to the record. And with that, I yield back to Mr. Chairman.
Thank you for your articles. That will be included in our record. And let's see, Mr. Evans. Can you unmute there? There you go.
Can you hear me?
Yes, sir. Go ahead.
Mr. Chairman, thank you. Mr. Chairman, I'd like to ask the question to Dr. Benjamin. Dr. Benjamin, as many as 20 million people lack access to the internet. And in my home city of Philadelphia, only 71% of residents had internet access in 2017. An article in March issue of American Journal of Public Health, which your organization published, points to the need for bidirectional communications, in which governments, health providers, and others use feedback from communications to better target their communications. Clearly, different populations need different communication channels to be reached, different messengers, whom they trust to understand and care about them. What technology solutions have you found most useful in the effort to address equity challenges?
Well, you know, there are several solutions. There's a thing called Text for Baby that was used to try to get mothers to get good early prenatal care. That was a system that was used many years ago. It's also been used to try to help people to get access to foods. But at the end of the day, you're going to have to communicate with them, and then you're going to actually have to take the vaccines into the communities to get people vaccinated. And also using community health workers that are actually going in door to door, banging on doors to talk to communities. Because as you know, even though people may know those communities are underserved, unless you actually go in the community with people that know the community and can reach those folks, you're not going to get them to come out and vaccinate.
Do you have any examples throughout the nation you can point to specifically relating to the communities of color?
There's a program that is being done out of the Tulane University by the Dean of the School of Public Health at Tulane University that's working with barbers and beauticians, and actually have people going into the community, banging on doors, talking to people. That's one program. The second one is the Cure Violence program in Los Angeles, which is a program that does violence interruption, but they have pivoted to getting their folks in the community actually going and talking with people door to door to engage them. Some of them are using text-based solutions as well as part of their interventions, but most of them, quite frankly, are doing one-on-one interventions and talking to communities and getting in those communities, just because not having access to technology is a really big problem.
You know, I don't know if you're familiar with, in Philadelphia, we have the Black Doctors Consortium. A group of doctors have gotten together and given the vaccines. Matter of fact, They did it one day
Yeah.
around the clock, and were extremely successful. Their numbers were greater than the city's numbers.
4,000.
Yes, exactly. You familiar? Yes, they did that. So, I mean, if you got that kind of model, I mean, obviously that's something we should use every and anywhere, works. I thank you for your comment. I thank you, Mr. Chairman. I yield back.
Thank you very much, Ms. Chu.
Oh, okay.
Sorry to skip over.
Yeah, thank you. Well, Dr. Jha, I've heard from the Pasadena Public Health Department in my California district, which is very eager to administer the vaccine. They indicate that they are able to administer at least 4 times the amount of vaccine per week than the supply they are allocated, and even more if there were vaccines that were provided to local providers and employers and additional pharmacies. I've heard similar stories from cities large and small in my district who are clamoring for more vaccine. But one issue that came up over and over again was the lack of reliable data, especially during the initial vaccination rollout. The Pasadena Health Department has to track who is getting vaccinated and the progress being made in the community. But individual providers did not report data to them accurately or completely, leaving out information on when the vaccine was administered and the race and the address of the vaccine recipient. Providers were also inconsistent in reporting their inventory on hand, and many did not provide a uniform system to individuals that were seeking the vaccine. And that wasn't specific, this kind of problem wasn't specific to individual providers, as contracted corporations like CVS and Walgreens also did not perform well either with communication or data tracking. So Dr. Jha, can you discuss the data challenges we've seen in this vaccine rollout and how Congress and federal partners can help improve on this data collection? And would the continued lack of reliable or incomplete data hamper our vaccination effort?
Yes, so Congresswoman, thank you for that question. And it really gets to the heart of this whole pandemic response. I'll come to vaccines in a second, but this is not a vaccine-only problem. The lack of reliable public health data has been a major reason why we have been consistently slow to respond to changes in the pandemic, why it took us months to figure out that it was disproportionately impacting communities of color. We have really had a hard time tracking infections and hospitalizations, and a lot of that has come about because private sources have come in and pulled together data. So we have a much broader problem in our country in the way that we have invested in public health data infrastructure. The HITECH Act from about a decade ago did quite a good job of getting money out to doctors and hospitals, but we have not put in similar kinds of resources into public health agencies, and we are unfortunately bearing the cost of that. And so that's the bottom. That's sort of the big picture overview. Now, when you come to your question around vaccines, this shows up pretty consistently day to day. Providers who are providing the vaccine don't always report that data as reliably as they're supposed to. The key pieces of information, like which vaccine was it, when was a person supposed to come back, that information isn't always conveyed. So, we have obviously got to find our way through it with this vaccination campaign because it's critically important that we get those things right. But as we emerge from this pandemic, we absolutely have to go back and say, can we bring our data systems up to the 21st century? Because this is no way to fight a pandemic where you're consistently blind, lacking information about almost every part of this pandemic. So this is a long-standing problem that we're unfortunately bearing the fruits of.
Yeah. Dr. Benjamin, recently we had a meeting with the city managers of my district, and they said that while they're all very supportive of the massive vaccination sites that are being supported by the state and federal governments, such as Dodger Stadium and Cal State University, Los Angeles, there are significant concerns with how to vaccinate the population of non-mobile seniors. In Los Angeles, if you don't have a car, public transit isn't always a realistic option, and many of these seniors are in assisted living facilities or other congregate care settings where they can't leave the facility once, let alone twice, to get their vaccine. So my cities said that they do have the ability to set up community-based vaccination sites that would help reach this population if the vaccine supply increased sufficiently to make such a thing possible. So Dr. Benjamin, can you discuss the benefits of incorporating community-based vaccination centers, such as community health centers, local governments, corporate partners like CVS in reaching these vulnerable populations, and what are the most effective ones?
So thank you very much, Congressman. So they're absolutely effective. One of the things I know CVS is doing, because I talked to them just the other day about this, is that they're first of all, they're reaching out to their established customers and contacting them. And as vaccine becomes available, they're going to reach out to get those folks in to get vaccinated. Second thing is they're doing pop-up clinics in inner cities, because as you know, many of these sites are not necessarily that actually have the vaccine may not be close to those communities, even though there is a pharmacy in those communities. Just this past Sunday, I had a chance to volunteer with my health department, and we went into the east side of the county, Montgomery County, Maryland. I'm outside Washington, D.C., and I got a chance to vaccinate people in a community which is about 80% African American, and it has the fourth largest prevalence of folks of color. And we were vaccinating people 75 years of age and older. In fact, I got to vaccinate a gentleman who was 100 years old. So I think by moving into that community, we were trying to demonstrate that you got to take the shot to the people versus bringing the people to the shot. Obviously, if you're in a congregate setting where you can't go out, you need to take it into that center, just like we did long-term care facilities.
Thank you very much. Dr. Winstrup?
Well, thank you, Mr. Chairman, and thank you all for being with us today. I appreciate it. You know, as one of the physicians in Congress, we were pretty well kept up to speed with what was going on with Operation Warp Speed, and really having a chance to have oversight to make sure that it's being done correctly. I always want to take a moment to thank all those Americans that got into these trials for this vaccine. Because they are really the heroes for us, because somebody had to trust that this was something that they should do. And I think we fail to mention that a lot of times. And this was quite a tremendous American project that really came to fruition when you think that our previous fastest vaccine took 4 years. And one thing I want to recognize, we talked about, look, the logistics of this thing is tremendous. And I think it was wise to bring in the Department of Defense, who's very good at logistics and getting things anywhere in the world in some of the best ways that we can. But I think what was also unique about this, that when a drug got to phase 3, we were producing 100 million doses. That has never happened before that I'm aware of. And so we're sitting here and we are complaining about supply chain, and we do want more vaccines out there. And I also appreciate what's being said today about they're all effective. I think that's an important point to be making to the American people. But we're really so far ahead of the game of what we've ever done before, and take a moment to celebrate that, even though we have troubles. And, you know, rolling something like this out is very challenging. Just look at the rollout of the Affordable Care Act, which had 2 years to prepare. So there are many challenges. And what I like is that we're talking about solutions to those challenges that we maybe didn't anticipate, or just think of the size of this country and how difficult it is. And so I don't really want to spend time like some have, you know, just being critical. A lot of people made mistakes along the way. That's not surprising. Even the scientists said, well, we think it'll go away this summer. And like other viruses do, but it didn't. Okay. So let's try to get away from the things that are in bringing out fear, and let's deal with what's real. And that goes whether it's the schools reopening or as we're rolling this out. In my district, I did have the opportunity to visit a new manufacturing plant that are making the coolers. Now, this looks just like a cooler you would take to the beach, but it can go to minus 100 degrees Celsius. That is unbelievable and a very amazing thing, but this is all part of the supply chain problem. And so the point is to, you know, get these out, get it out as best we can, as fast as we can, and do it right. But I know it's frustrating, but let's keep working on it. We've heard a lot of solutions. We've heard from West Virginia where things worked. You know, I still serve in the Army Reserve, but I went out with our National Guard to do drive-up testing. And I'm going to go out with the National Guard to do drive-up vaccinations as well. And in one of my rural counties, they used their fairgrounds, and volunteers, nurses, doctors from that community are out there putting shots in arms, driving through the barn at the fairgrounds. It's working, and it's the community that's doing it. And so it seems pretty clear that we have a problem with supply, because what I've seen is as soon as they get it, they're getting it out. And I appreciate some of the challenges that Dr. Benjamin talked about and Mr. Evans talked about, getting into the communities. I'll be glad when we have this very much great supply at our federally qualified health centers. I think that's going to be important. But one of the things that was supposed to happen is going back to November 1st, states were supposed to have a plan for distribution and the personnel in place as best they could. And obviously that didn't happen the way that it should. And that was before the vaccine came out. So the best intentions were there. But I want to ask Dr. Marsh, since they did so well in West Virginia, would you say on November 1st, was West Virginia ready to go, or did you develop these best practices as you went?
Well, thank you, Dr. Winstrup. I really resonate with your comments. This is the most complex operation we've ever done in our country, in my opinion. And so we are all learning as we go. Certainly, I think that your comments are absolutely right on. The fact we have really effective vaccines is fantastic and really unprecedented. But I do think that as we go forward, the one opportunity that we have is to share more with each other. I do think that we have not shared enough between states, and even though we're all different, there are similarities. I think that expertise in logistics and supply chain become really critical for our future.
Thank you very much, Mr. Schneider.
Thank you, Mr. Chairman. I want to thank you for holding this critically important meeting today, and I want to thank our witnesses for sharing your perspectives with us, your insights on what I know has been a long meeting. Every one of us, every member on this committee has received just an incredibly deluge of outreach from our constituents. Everyone asking when and where can we get our vaccine. Their messages are often a mixture of hope, fear, and anger over the current state of the vaccine rollout in our country. Now, it's true the previous administration prioritized vaccine development, but I also think it's fair to say that they completely failed to put into place sufficient planning to ensure those shots got into people's arms efficiently and equitably. As was just noted, this is an incredibly complex operation, in part because of its scale, the entire country, and in part because of the timing. It has to be done as quickly as possible. But a vaccine is only as good as it's supplied and the distribution chains allow it to be. The Biden administration has worked diligently to rectify what was left behind by the previous administration, including increasing supply by 70%, deploying thousands of vaccinators and support staff across the country, including today announcing that we'll have a mass vaccination site in Chicago and other places, and dramatically increasing the number of vaccination sites across the country. However, too many Americans are still facing hurdles in getting their needed vaccines. Now, I've come to think about this problem concisely in what I call the 4 Ps. Product, making sure we have enough vaccine to vaccinate the entire country. With the addition of the Johnson & Johnson, we're making good progress towards that. Prioritization, making sure we're getting it to the people who need it the most urgently and getting to everyone as quickly as possible. Place, and as someone else said earlier, the closer people are to where they can get vaccinated, the more likely they are to be vaccinated. We've got to get it to more places. And finally, process, the ability to get on an appointment, to know where to go, when to be there, and know you're going to get your shot, and if necessary, a second shot. We are struggling with all of these issues, but I think more than anything else, we are struggling with that process issue. People are really frustrated in their inability to know where to be, when to be there. So if I can, Ms. Lewandowski, you mentioned some of this in your testimony, but I was hoping you could elaborate on the steps you think we need to take at the federal level to improve that process, that scheduling capacity. What should we be doing as members of Congress to try to help facilitate that? And then if there's time left, I would like to give that to Dr. Jha to respond to the earlier question.
Thank you. So as Dr. Jaw said, and as I mentioned in my written testimony, we do have a map called Vaccine Finder. It was turned on yesterday, but it has very limited data for many states. This could help. I have noticed that my own state, Wisconsin, has just overlaid another location finder. One of the things that you can do as elected representatives is help the CDC collect these individual locations, because if you're in a family like mine, I have parents in California, Colorado, and even in Florida. And so if I were to need to help them, I would want a national location that I could go to say, where is the closest place for them to be vaccinated? Then we need to fund additional registration systems. My own state in Wisconsin has a public health registration system that's rolling out, but it is only limited to a few public vaccinator locations. These state registries should be available to every provider, and it should interface with their electronic medical record in current scheduling capacity. And so finally, I would also add that adding capability for hotlines, phone hotlines, very robust ones, must be added. You know, that with the 211 system, that could help people find, look on Vaccine Finder and help people know. So there are so many steps, and I have outlined many of them in my written testimony. So I hope that you read it, and I will yield the rest of my time.
Thank you. I appreciate that. And yeah, people are so frustrated about getting the appointment. Anything we can do will help that. And with that, if Dr. Jha would like to respond, I'm happy to yield my time to him.
Yeah, so Congressman, let me just add a couple of things. We're missing a really big opportunity right now, because here's what's going on. Right now, we're in a situation where we have much more demand than supply. I promise you that in 2 months, we're going to have a lot more supply than demand. And we're going to wonder what happened to all those people who were knocking on the door who have not gotten vaccinated. And we're not doing anything to keep track of them. What we want is a simple system. Everyone should be able to sign up based on whatever priority your state has created. You get vaccinated. And we want to take all the people who are lower priority, let's say a younger, healthy person, who we want vaccinated in May when there's plenty of vaccines around. And we keep them engaged. We don't say, come back in May. Right now, if you try to go get vaccinated in Massachusetts or Rhode Island or pretty much any state, if you're not eligible based on current things, it says come back in 2 months. This is not how we should be doing this. So we've got to push our states to have simple systems that draw people in. Look, send people an update by an SMS text message every week saying, you're 3 weeks away or you're a month away. Keep people engaged. We're going to need them vaccinated in a month and a half. I feel like we're just missing this massive opportunity. It breaks my heart to see how we're handling this.
Thank you. My time has expired. I yield back.
Thank you very much, Mr. Estes.
Thank you, Mr. Chairman. Thank you for allowing me to join this committee for the very important hearing. And I want to thank our witnesses today as well. You know, vaccines are a key part of reopening the economy and returning to our normal American lives. Thanks to the Trump administration's Operation Warp Speed, we're able to help bring about successful and effective vaccines to fight COVID-19. It's an incredible achievement for the United States. You know, without Operation Warp Speed, we still would not have vaccine for several years to come. With vaccines and a better understanding of how the virus operates, it's now necessary that we start to work on how do we return to normal. That means getting back to school and getting back to work. And to do this, we have to make sure we get shots to whoever wants them as efficiently as possible. In December, the Trump administration began this process, ensuring that states receive doses of the Moderna and Pfizer vaccines, allowing them to tailor distribution to the needs of their communities. While some governors leveraged existing state distribution channels and funding from the CARES Act, others hampered health officials with unnecessary red tape and political gimmicks. I'm disappointed that my state of Kansas has been slow to distribute vaccines to high-risk Kansans in rural areas. Kansas has been last in the country in getting people vaccinated for several weeks of the vaccine's been available. And further complicating these efforts has been Kansas leadership has struggled to report accurate information to the CDC. Yesterday, the CDC reported that nearly 755,000 doses have been given to the state, with nearly 531,000 doses administered, while the Kansas Department of Health and Environment is reporting that nearly 695,000 doses have been distributed to the state, with only 506,400 doses administered. These numbers are off by tens of thousands, unfortunately. It's clear that many states have to work to improve the distribution process immediately. That starts with better collaboration between agencies involved. I want to urge state, local, and federal officials to work together with others to find solutions and get the job done. Now's not the time to duck that responsibility. Millions of Americans are counting on the transparent and efficient vaccine distribution to see loved ones again, or to worship again in person. I know Americans are ready to get back to work and get back to their lives. It's time that we focus on helping make that happen. I look forward to working with my colleagues to further protect Americans from the virus and ensure that our nation is prepared to handle future threats to our public health. Dr. Marsh, in the state of Kansas, we've had a great deal of struggle working with the rural counties. And similar to West Virginia, we have a mixture of urban areas as well as rural areas. So the leadership in Kansas has been struggling with balancing the vaccine distribution across all of those counties and keeping up data reporting to the CDC. What suggestions do you have from one state to another to get more shots in people's arms and ensure that we're meeting all reporting requirements?
Thank you, Congressman. I think that is a challenge for many states. For us in West Virginia, as I said, that we have established now a vaccine place in each one of our 55 counties. We have allocated the vaccines based on the percent of that population per county that has our prioritized population, either essential workers over 50 or citizens over 65. And we work to make sure that each allocation of vaccine is utilized completely by the end of the week so that we zero out every week. And because we have pharmacists that manage the vaccines, that we are consistently getting 6 doses of the Pfizer vaccine out, and we're oftentimes getting an extra dose of Moderna as well, which gives us a rate of vaccination over 100% of what we're given allocated. Although now that's changing the way that things are being counted. So I think that having the rigorous and disciplined supply chain so that you track your vaccines, that you're not giving excess amounts of vaccines, that you're giving vaccines to places where you know they can be delivered. But the most important thing, and this has been mentioned before, is this is not about coming up with some number or ranking or some responsibility that is a burden. This is about taking care of your community. This is about saving people's lives. This is about taking care of your neighbors, your family. It's very, very personal in West Virginia. And I think that that's the spirit that is helping West Virginia do well, because people are doing this out of love for each other, as opposed to out of a sense of burden for some ranking.
Well, great. Thank you, Dr. Marsh. It is important that we get the vaccines distributed. We don't lose any to waste, and make sure that it gets out and distributed across to all the population. With that, I yield back, Mr. Chairman.
Thank you. Mr. Gomez.
Thank you, Mr. Chairman. I appreciate it. I've enjoyed listening to people's presentations. The issue of the distribution of the vaccine and the equitable distribution was always a top concern of mine, even in the early days of seeing who was getting tested for the COVID vaccine. And it was COVID for who had COVID. It was completely foreseeable. All this was completely foreseeable. It was just, which really makes me angry. So it makes me so livid. Sometimes I would want to bang on this table, even though I know that there's no one here to feel it, right? But it makes me extremely upset. I represent the east side of Los Angeles, a very immigrant Latino neighborhood, and there's a lot of challenges. I also have the largest Korean population in the country. I have a Chinese population, Filipino population. So it's really complex. But I always knew, and maybe some folks, I know some people on here were on Oversight with me. Same thing with the census. The places were going to do the worst were the ones that didn't have access to broadband, didn't have access to internet, or were too much reliant. So all of you all know that, and it just really makes me upset to an extent that we're doing better, but it has to be quicker, right? It has to be quicker. And I always say that we're going to be not judged if we get out of the pandemic, but if our communities that are the lowest income and people of color died at proportionally high rates for their population size and their percentage. That's what we're going to be judged by. Just like in a famine that or a dry spell, who's getting impacted? And it always tends to be the poor people. It always tends to be the immigrants. I have a few questions. One, there are some instances where there's vaccine jumpers, right? The people that are not in the tier going to trying to get in, right? And some of them, and there's been stories in the LA Times that has happened. What are some steps that are being taken in the other states? I know Dr. Marsh, I don't call on the Republican witnesses, but you said something that piqued my interest. You said we're really strict on the categories. Can you kind of get into that a little bit? And then I'll ask Ms. Lewandowski from Wisconsin.
Thank you, Congressman. You know, we believe very deeply that a vaccine in an arm of our prioritized population will save lives. And that becomes a really sacred duty. And so part of what we do is we work with all of our vaccine centers, and we're not inflexible. Of course, if somebody comes in and they're with their spouse and their spouse is 64 years old and they're 66 years old, we'll of course administer vaccines. But we make sure people have valid, identification with residents in West Virginia. But also we have really tried to articulate, communicate well to our citizenry, not only the people that are eligible in our priority schemes to get the vaccine, but to ask our population to defer that sort of gratification so that you're really caring for somebody else. We're calling on better angels of people. And one of the things about West Virginia, although in many ways West Virginia may have been felt to be left behind in some ways, this spirit of community and family and service is something that really resonates. And ultimately, our citizens have been so good about saying, we'll wait our turn. We'll wait our turn so other people can go first. And as I said in my earlier statement, and I'll be short, we have seen an 85% reduction over the first 7 weeks in the deaths in West Virginia, which is unbelievable and really a testament to our citizens' ability to defer for our really highly prioritized population.
And Ms. Lewandowski?
Thank you. So what I believe and what I have seen in the data that has been replicated in Milwaukee and other areas is these communities need to be served. They need to be served by the doctors who know them. And so they know that they are a part of the community. As somebody who did prioritization in Wisconsin, I am horrified when I see a 33-year-old healthy person receiving a wasted dose when that could have gone into the arm of a 65-year-old. But really, that's where you need to talk with your providers, help them understand, help the public understand, as Dr. Marsh said, why we are prioritizing people so that there is less anxiety and so that people are willing to come in, and we know that Black and Brown communities are eager to be vaccinated. But also make sure that that public health infrastructure comes to them so that it is delivering to them where they are, rather than dragging them into other locations that may be challenging, through partnerships with Lyft and others that are very successful.
Yeah, thank you. And I'm out of time, but I wish we didn't have these 5 minutes limits right now, because there are things that we can all learn from each other's states, right? It doesn't matter if you're a red state or a blue state, it's about who's doing the job well. So I just want to commend all the states that are doing the job well. That's the only way we're going to make people feel that we're all in it together. So thank you. With that, Mr. Doggett, I yield back.
Thank you, and that's so very true. Mr. Horsford?
Thank you, Chairman Doggett, for leading this important hearing, and thank you to our witnesses for your incredible insight. I want to start by saying thank you. Thank you to all of the individuals who are helping on the front lines of this pandemic to crush this virus. I want to say thank you to the National Guard, to the first responders, to the healthcare workers, to the health agencies, and all of the other local officials who are doing all that they can to defeat COVID-19. We are going to crush this virus, and we're going to do it together. I had an opportunity a few weeks ago to visit a couple of vaccine distribution sites in my district to listen and to learn directly from these individuals what I needed to be doing as their representative to better help my constituents get access to the vaccine. And that's why I'm voting, in fact, today to pass the American Rescue Plan so that I can give the support that is desperately needed for us to win this war against COVID-19. In Nevada, cases have declined 55% in the past 2 weeks, and we continue to see a downward trajectory in hospitalizations, and our state has the 9th highest COVID-19 vaccine utilization rate, using 91% of our allotted vaccines, while the national average is 85%. Well, recently I conducted a telephone town hall. I spoke to Gwen, a constituent from Las Vegas, who is a primary caregiver for her 85-year-old mother. She asked that as the caregiver of her mother, would she be able to get the vaccine at the same time? Gwen is 60 years old, and according to our priority guidelines, she is not, unfortunately, in a priority group to get vaccinated yet. This is a missed opportunity because according to the Washington Post article, Black, Latinx, and Native American communities are twice as likely to die of COVID-19 and are dying at rates significantly higher than their white counterparts. That's a racial health equity issue that we must address now, and another reason why we must pass the American Rescue Plan. Dr. Edwards, if Black Americans have shorter life expectancies and other people of color, and a higher incidence of chronic health conditions, shouldn't policies consider these disparities in prioritizing groups for vaccinations? And what are some approaches that we should be taking to vaccinate people at younger age cohorts to avoid this issue?
Thank you so much for that question. Absolutely, partnerships are important. Your story resonated so much with me here in Texas. I'm very proud of the partnerships that we've been able to create to have drive-through vaccines. And in fact, tomorrow we'll be having a mass vaccination effort to vaccinate 3,000 in our community at a local racetrack. And so those partnerships, whether it's with bipartisan county judges, our FQHCs, our public health departments, our hospital systems, it just resonated so much with me to hear what your constituent said, because I vaccinated a 103-year-old woman whose daughter also brought her and asked me the exact same question. But with these partnerships, we have opportunities to keep in contact with these individuals so that when we bring the 103-year-old former teacher who now serves as such an example to her former students who are in their 70s, and she was so proud to tell us that. When we bring her back, I know her daughter's going to be there. And if we have that communication opportunity through these partnerships, then when we do get the vaccines like Johnson & Johnson, we will be able to have her aware, regardless of prioritization. As we get more vaccine, we will be able to vaccinate more people. And it is through the partnerships that we have seen so successfully here at Ascension, Texas, and Ascension nationally that will get us to where we need to go so we can be in contact with our families, with our patients, with the individuals that we know, at least within our system, are those that are highest risk because of race, ethnicity, social determinants of health.
Thank you. Dr. Lewandowski, just quickly around the community healthcare workers and their effectiveness in being able to reach those who are the most vulnerable and most in need of the vaccine. What barriers exist due to the lack of consistent mandatory funding for health departments could we be addressing to improve that issue?
So we know a messenger who looks like us, who feels like us, is going to be effective. And I know in Wisconsin, most of our health departments do not have the ability to hire community health workers. So what we have been trying to do is partner with community programs like the National Council of Negro Women. These are very involved women. They are out there. They know their community. And so letting them know, hey, there's a vaccine clinic. Get this out to your network. And helping them become de facto health workers is what the model that we have to do, because we've not had the funding to hire these women and train them as community health workers, even though they are performing that role.
Thank you, Mr. Chairman. I yield back.
Thank you. Mr. Rice.
Thank you, Mr. Chairman. For the experts on this panel, this bill contains $100 million, I think, to build a subway in California. Do you think this coronavirus rescue bill, building a subway in California, is going to reduce the incidence of coronavirus? Just anybody? Yeah, I didn't think so. It's also got close to $1 billion for a bridge in New York. I'm wondering if you experts believe that that's going to reduce the incidence of coronavirus. Yeah, I didn't think so. It's also got $65 billion to bail out union pension plans that have been chronically underfunded. Any reduction in coronavirus? I didn't think so. Moving on to more substantive things, Dr. or Ha, I'm not sure how to say your name, sir. You really said some things that were interesting. You said that once we got to 50% with immunity, there would be a big drop off in infection. And you said you thought, by your estimates, 85 million people had already been infected. And I've heard even higher than that. In fact, I'm sure you know there was a physician in Johns Hopkins last week who said that he thought coronavirus would be in steep decline in the next month. So you think 85 million infected, that's 26% of the population. According to CDC, 14% of the population has been inoculated. So that's 40% right now, today. And we're doing, according to the Biden administration, 1.5 million vaccines per day. So every 2 days, that's 3 million people, or 1% of the population for one dose, 4 days for 2 doses. So every 4 days, we add 1%. So in 40 days, we'll be at your 50%, if my numbers are right. And not only that, that doesn't factor in the 80,000 people a day that are currently getting infected. So over 40 days, that would be another 1%. So we'd be at 51% in 40 days at current levels of vaccination. Do you agree with that, sir?
So Congressman, just one small disagreement on the math, which is, remember, we're vaccinating some people who've been previously infected, so you can't just add those two groups together. But that said, so this is, I don't think we're at 40% right now. But to your point, the bigger picture point you're making, sir, I do agree with, and I don't think 1.5 million doses a day is where we're going to be. I think in much of the month of March, we're going to be at 2 million doses a day, and maybe even closer to 2.5 million doses a day.
Okay, so I want to go to Mrs. Lewandowski. Mrs. Lewin, I'm sorry, sir. I want to give you more. I don't have that much time. Mrs. Lewandowski, you said that you're requesting 400,000 doses, but you're only getting 120,000 doses. Well, I mean, I understand why you're not getting 400,000, because Wisconsin makes up about 1.75% of the whole population of the country. So to get you 400,000 doses, we'd have to be making 3.5 million a day, and nobody thinks that that's in the immediate future, right? So you're not going to get your 400,000 a week, excuse me. You're allocated 120. Now that, didn't you say 120 is what you're allocated? 120,000?
Beginning this week, it's 120. We were at 71,000.
Right. So here's what worries me. Here's what worries me, because I want the public to have the truth. You know, I mean, whatever the truth is. And a month ago, we were inoculating 800,000 a day. And then 2 weeks ago, we were at 1 million a day. And now we're saying it's 1.5 million. But if you only get 120 and you do the math on that, Wisconsin's a portion of the population, that would mean we're only doing 1 million a day. Has that 1 million, yeah, that's right, 1 million a day nationwide. Has that number varied by week?
So yes, it has varied by week, but also it's important to remember that I was very specific that this was first doses that were requested.
Okay, so you're getting more doses than that.
Yes, we get second doses automatically shipped.
So how many doses are you getting per week now?
So the number of second doses is not highlighted and publicized as well as we would like. So transparency around that would be very good.
So you could, okay, that makes me feel better about those numbers. And Dr. Marsh, I wanted to speak to you and just amplify what Mr. Horsford said and others. I have 8 counties, some more urban than others. There's South Carolina publishes a dashboard of how the county inoculations are going. And at first, every state, this massive rollout is going to have wrinkles. And we weren't getting vaccines in arms. And our governor, to his credit, lit a fire into the hospitals. He actually said, if you don't put your vaccines in arms, we're going to end elective surgery in South Carolina. We will do an executive order to end it. And guess what? They got vaccines in arms. But the problem is, in their haste, they're doing it in urban areas, right? Because they want to get the vaccines in arms, and it's the easiest place to do it. So, for example, Charleston County has 126,000 vaccines in arms. Marion County, which admittedly is 10% of the population of Charleston County, and these poor folks have heard me talk about Marion County. So it's poorest county in South Carolina, 50%, 57% African American. You know how many vaccines they've had? Charleston County's got 126,000. They've had 365.
Wow.
365.
Wow.
So, there's a problem with facilities in delivering that. There's a problem with people being mobile. Just your number one specific suggestion on how we take care of those folks.
Very, very briefly, if you would, because he's way over his time.
Absolutely. I think it's that same sort of commitment to each citizen as part of our larger community, and that we feel like that this is our duty.
Thank you. I yield back.
Thank you. Mr. Kildee.
Thank you, Mr. Chairman, and to all the witnesses, thank you. This has been a very helpful, informative hearing. I would like to focus just for a moment on, and I know we talked a little bit about this, I think Mr. Blumenauer raised it, around the Johnson & Johnson vaccine. We've heard from their executives that emergency use authorization would allow them to have, correct me if I'm wrong, maybe Dr. Jacques, start with you, something in the neighborhood of 20 million single dose vaccines available to ship by the end of March. So I guess maybe comment on that in terms of what you think the scale is. But my question, and I would ask Dr. Jha to comment, but maybe if other panelists want to comment. My question is some of what I'm hearing from folks, and that is just, they're just trying to figure out, how to game this out. If Johnson & Johnson becomes available, I'm hearing from some, well, I don't know, maybe I'll wait and see if Pfizer or Moderna is going to be available. I'd hate to, get one and then a few weeks later have another available to me. I think you kind of get where I'm going with this. Could you help us understand, any of you, how you think we should address this question, knowing that the efficacy of each is unique and different, but all very high? And then one other question that came up when I was in a meeting with the Michigan State Medical Society, and that is a concern to somehow engage physicians' offices in the relationship physicians have with their, with their own patients regarding distribution. Start with Dr. Jha, but then I'd ask any other panelists to join in.
So absolutely, Congressman, a couple of great questions. 20 million doses in the month of March is huge. Because remember, it's single dose, so it's equivalent of 40 million doses of a Moderna or Pfizer, except you don't have to come back 3 to 4 weeks later. I think one of the reasons I am so optimistic that we're going to get to very high levels of vaccination as we get into May and June is because Johnson & Johnson is going to be on board. We're going to have plenty of Moderna and Pfizer vaccines. And the hope from Johnson & Johnson is that we're going to get to 100 million doses by July of just that. Remember, that's, that would be amazing. So certainly by midsummer, everybody in America, and probably earlier than that, everybody in America who wants a vaccine will be able to get one. In terms of the communication, it's really a challenge, and so much of this is about how these vaccines get reported and the trials, the way they design them. And again, these are incredible trials. I'm not beating up on anybody, but the headline number they report is not actually the number anybody really cares about. And it's very hard to capture in a one-line headline in a newspaper or in 30-second blurb on CNN. And again, those guys are doing the best they can, but that's just the reality of this, which gets to your broader point, which is this probably would be ideal if people could sit down with their physicians and have this conversation. Because as I have said previously, I would be delighted to take the Johnson & Johnson vaccine. If I had a J&J vaccine available today and a Moderna vaccine available tomorrow, I'd be happy to take the J&J today. I don't feel like I would need to wait. They're all terrific vaccines for the things that we care about. And unfortunately, if we find ways for patients to engage with their physicians, it would make an enormous difference, because then physicians and nurses can help patients understand these issues. They're complicated and they just don't fit on a headline.
Thank you. Other panelists?
Yeah, Representative Kildee, thanks for this question. I'm a primary care physician. I get this question pretty frequently from our nation's veterans, but other folks that I also see in the community. I echo a lot of things that Dr. Jha would say, but one of the concerns I do have is that Johnson & Johnson also had delays like the other manufacturers in terms of promising supply. And so because we have kind of relied on these companies on being open about their supply and their supply chain, we kind of are left knowing kind of a little bit too late sometimes about how much supply there is. And so I would tell my patients that because of this, because of unexpected delays that are occurring, despite the public having funded the technology and also production, that they should take any vaccine that's going to be made available to them. And if the U.S. government did step in to help ramp up supply, this would mitigate a lot of the questions that are coming up during this panel about prioritization and those tough decisions if the government did step in to lay claim on this publicly funded technology in the first place.
I wonder, Ms. Lewandowski, if you could comment both on this question, but particularly as it relates to the Johnson & Johnson vaccine, you're thinking about the impact that this might have on rural populations. It would seem to me that the storage flexibility that comes with it, the fact that it's a single shot, may make it, and I don't know that we game out, particular vaccines for particular populations, but I wonder if you could just comment on the efficacy of, from an operational standpoint, of targeting the use, perhaps Dr. Marsh have a thought on this, the use of that particular vaccine in rural communities where the storage issues and the transportation issues might argue for that.
Thank you for that question. What we have always...
Sorry, I can't really hear you. I think it's...
I'm sorry. The position that we have always taken for rural communities is the minimum order is more important than storage, and the number of doses in a vial is critical for that flexibility. I believe that you're absolutely correct that providers and doctors who know that their communities should have the flexibility to order that vaccine. That should not be something that is driven by politics or any sort of policy. But I do believe that people who are serving vulnerable populations, whether they're rural, whether they're urban, will know if it is feasible to come back to have the same group of people show up a month later and all of that. I know even there is some acceptability positives with the Johnson & Johnson vaccine. The Moderna and Pfizer vaccines were subjects of misinformation campaigns for months before they were released. And the mRNA technology is not well understood. And we are lucky that the Johnson & Johnson has not had that same campaign, which means that some people who are distrustful of the Moderna and Pfizer platforms may be more willing to accept the Johnson & Johnson even if it seems like there is a lower efficacy with that headline number. But again, I would reinforce and say that these are different trials. They had different variants, and it's still a great vaccine.
Thank you very much. Let's see, Ms. Miller.
Thank you.
Thank you, Chairman Doggett and Ranking Member Nunes. And I want to specifically thank you for allowing me to take part in this today, because it's so very important. And to every one of you witnesses, thank you so much. This is such an example of how important it is that we talk to each other and we listen to each other. It makes an incredible difference how we move forward. And I also want to make a comment about Dr. Wenstrup and how, with him being a congressman as well as a physician, I think he really has a perspective that is very fair and something that we should listen to, because that has been his life, and he can share things with us in a very bipartisan manner. West Virginia has been leading the nation in distributing vaccines. On Wednesday, our governor, Jim Justice, announced that if West Virginia were its own country, it would rank 7th in the world for its rate of vaccination. Given how rural our state is, this has been a mammoth undertaking from federal, state, to local communities and stakeholders. West Virginia has come together to ensure that we can efficiently and effectively get the vaccines to those who need it the most. No two states are the same, and that is why we cannot mandate a one-size-fits-all approach to vaccine distribution. However, we have seen many states tie their own hands, and they have gotten into political correctness of who should be vaccinated and when we must keep our eyes on the ultimate goal, which is vaccinating as many Americans as possible, as quickly as possible, so that we can reopen our economy, reopen our places of work, and get our kids back into school. Dr. Marsh, thank you for your testimony. You illuminated the great efforts West Virginia has undertaken to save lives. Will you elaborate on the success of Operation Save Our Wisdom and tell us why this was such a critical first step for the state to take?
Thank you, Congresswoman. Well, and thank you for your service to our state and for each person here. This is absolutely a bipartisan issue that we're dealing with. One of the things that's really striking, so Governor Justice really focused our vaccination priority on our older part of our population. But for those of you who don't know this data, it's something that I find incredibly powerful. This is CDC data. So if you compare 18 to 29-year-olds who are infected with COVID-19, and you look at hospitalization risk and death risk, then 50 to 65-year-olds versus 18 to 29-year-olds have a 30 times risk of death and a 4 times risk of hospitalization. 65 to 75-year-olds have a 90 times risk of death and a 5 times risk of hospitalizations. 75 to 85-year-old Americans have a 220 times risk of death and an 8 times risk of hospitalizations. And Americans over 85 have a 630 times risk of death and a 13 times risk of hospitalization. So as we target and focus on saving lives and reducing the burden on our hospitals, then it becomes very obvious that we want to vaccinate our elders. And as I mentioned, our nursing home population was half of our mortality, as it has been in many other states and countries. And today, in many of our nursing homes, we have no outbreaks. We have single numbers of death across whole nursing home segments. So this approach is highly effective. And I would say, and I've heard Dr. Jha talk on TV before and other people, that I think a single dose of these vaccines is very, very effective. And I'm not saying we shouldn't vaccinate with 2 doses, as FDA has said, but it is really, I think, incumbent upon us, particularly with the viral variants that are starting to come forward, for us to get as many first shots in the arms of as many of our citizens as possible. And if you target our older population, then you have a fighting chance at really not only helping reduce the replication errors, the variants, but also of saving a whole bunch of lives. And in West Virginia, as I say, over the first 7 weeks of 2021, we've seen an 85% reduction week to week in deaths in West Virginia. Thank you.
West Virginia also has had a unique utilization of local pharmacies in distributing vaccines to our rural communities among the hills and hollers. Can you describe how West Virginia has tackled the challenges of rural healthcare?
If you can briefly, thank you very much. And thank you,
That'll
Mr.
be very short. Well, thank you, Congresswoman. I think this is really, really critical because this is where the personal relationships come in. And for instance, in our nursing home population, I think national average 71% of the residents and 30-some% of the staff, because of our pre-existing relationships, we had 85% of the residents and over 65% of the staff agree initially to be vaccinated. So this is really about us caring about each other and giving these personal relationships an opportunity to really make an impact.
Thank you so much. I yield back.
Thank you so much. Mr. Byer, can you wrap this up?
I will. Chairman Doggett, thank you for doing this. I'd really like to thank all of our experts for hanging in over 3 hours to talk to us. I want to, something that Congresswoman Miller just talked about, the local pharmacies. And Dr. John, I'll give you sort of a different twist on it. Because I think the Biden administration has done a wonderful job ramping up the vaccines, but the Federal Retail Pharmacy Partnership Program is causing a lot of confusion in Virginia. We've got a very good state system, good local systems that are pre-registering folks. And instead in DC this morning, we saw this panicked lottery. This pre-registration system allows local health departments to work together with the state to proactively address inequities, get the vaccines to the right people. But the Federal Retail Partnership Program is completely disconnected from the state and local health departments. And if there was tons of vaccine, that might be okay, but there isn't. Can you speak to the inequity problems that the Federal Retail Pharmacy Program is creating? The multiple websites, the need for computer access, well-resourced folks getting vaccines outside their health district, even crossing state lines. It actually reminded me this morning of when I was a teenager calling the radio station to try to get concert tickets, when you had to call every couple of minutes, and it wasn't necessarily to the most needy, it was to the most manipulative.
Yeah, so Congressman, couple of thoughts, and thank you for that question. And it has been a real problem. So on the long-term care facility side of this federal partnership, West Virginia went a different direction, and obviously Dr. Marsh has laid that out, and it's well known. What's interesting is I look across the country and I see 3 states that have done a superb job. There are many actually, and I don't want to but I'm just going to single out 3. West Virginia is certainly one of them. Connecticut is another one, and New Mexico is another one. So 3 states, very different approaches. Connecticut stuck with the federal pharmacy program for long-term care facility, but they were very, very aggressive about making sure that all of the hangups and all of the problems that many states were facing, they solved them. They really, really kind of were proactive and aggressive. It's just my way of saying, with the right focus, you can get these things. You can get these things solved. You know, on the issue of inequity, there's 2 quick points on this. One is just to address something Dr. Marsh said. One of the problems of the first dose and then followed up with everybody needs a second dose right away is in the first pass of the first dose, almost everybody who got these vaccines were white. Let's just be very explicit. There were very few Latinos, very few African Americans. Now we're spending the next month giving all those folks second doses. We're giving out more second doses than we are first doses right now. So if we want to expand the issues of equity and try to get more vaccines happening among African Americans and Latinos, it's going to be very, very difficult because we're right now spending almost all, a large chunk of our time giving out second doses. So something to think about in terms of the issue of delaying that first dose and letting other people, vulnerable people, get their first dose. On the federal partnership on pharmacies, I agree with you that it has certainly opened up a lot of opportunities for gaming. I think my general strategy has been you got to get vaccines to the communities that you want to target, and you've got to work with community-based organizations. Chicago Oak Street Project, I think it's called, has been one of the kind of highlights of this. So there are ways of doing this, but the issues you raise really are things that we're going to need to address going forward.
Thank you very much. I want to jump on one neglected group of essential workers, and that's federal government employees. We have so many Social Security workers and IRS workers and others who are essential to keeping this economy going, who can't work from home. And yet they're necessarily been put behind people that have pre-existing conditions or are older. You know, as Dr. Marsh talked about, people my age that are a lot more likely to die. But we're trying to, so we've come together asking CDC, maybe Ms. Lewandowski, you might have her perspective on this. Federal employees are scattered all across all 435 congressional districts, is trying to ask the federal government to help get them to this group of essential workers.
So I'm delighted that you asked this question because it has been a question that has been plaguing me in my role as co-chair of the State Disaster Medical Advisory Subcommittee on Vaccine Distribution in Wisconsin. So when we were making our priority groups, we were told that at least U.S. postal workers who are federal employees, and this was in January, and I mean no criticism, but we were told that U.S. postal workers and other federal employees would be covered by vaccine supply, similar to those working at the VA. Now, my understanding, due to the suspension of the SDMAC, is that that has not yet happened. And so I think that that is a question to be posed to the administration, to CDC. Where do these people fit in? They should absolutely not fall through the cracks. They should be addressed through some system, whether it's federal, whether it's state. But yes, I agree, these people need to be served.
Thank you. I think I have a very generous clock, but one quick last thought for you, Dr. Jha. And I asked this as the parent of two Brunonians. One of my Republican pals earlier today said, why not just herd immunity? You know, what if we'd not done mass social distancing, shut down our businesses? Instead of the 500,000 dead that we have, where would we have been?
Yeah, you know, we don't do herd immunity for any deadly infectious disease for a reason. It kills a lot of people, and it often doesn't work because over time, immunity can wane. You have new people being born into our society, children, and then you have to have a strategy where you're constantly getting kids infected. It's not what we do when we have alternatives. We would have had many more thousands, hundreds of thousands people die if we'd really taken that strategy. And the other thing, of course, something I brought up, variants and mutants arise when you give the virus lots of chances to infect people. All of these variants have arisen in the context of large outbreaks. If we had let these outbreaks just run, I can promise you we'd have many more variants to deal with, many more potentially deadly ones. So it's not a good strategy. It's not a serious strategy. And I think, you know, the strategy that you got to do is you got to get as few people infected as possible, build good treatments, good diagnostics and vaccines. We've done well in some of those areas, less well in other areas. I do think that we are going to be able to get through this now with the vaccines, 3 vaccines that we have. We'll have probably 1 or 2 more, and then we have to make sure we do better next time.
Thank you very much. And thank all of you for staying to the very end.
Yes,
Chairman, I yield back.
Dr. Jha and Mr. Byer, thank you. This is a very good point for us to conclude our hearing on. We've gone a full 3 hours, and I think each of our witnesses has made a real contribution to our understanding of the complexities and the challenges that we face. Our members do have a couple of weeks in which they can submit written questions, and those questions and answers are made part of the formal hearing record. I do appreciate all of our colleagues, both those who are on our subcommittee and several who joined us from the full Ways and Means Committee, for your participation. It's been very helpful. I hope we can continue working together to address this vital health issue. Thank you, and that officially concludes our hearing.